please raise at the time. We'll now move on to agenda item 3, the minutes from the 15th of December 2021. These can be found on pages 3 to 12 of the agenda pack, and as the committee have had the opportunity to read these in advance of the meeting, I plan on taking these on block. Do I have a proposer for these, please? Thank you, Councillor Wotton. Put my own teeth in. Okay, thank you. Do I have a seconder for those, please? Thank you, Councillor Hayes. All those in favour, please show. Thank you. Any abstentions? Thank you, Councillor Whittington. Any against? No, in which case they're carried. Thank you. We'll now move on to agenda item 4, the Chairman's announcements. My announcements have been circulated with the agenda from pages 13 to 15, and my supplementary announcements were emailed on the 18th of January. Are there any questions on these at all, please? Councillor Smith.
Thank you. Excuse me. Thank you, Chairman. I read with interest around EMS, around the need for members of Her Majesty's Armed Forces due to the current staffing restrictions. Is that still in place? Because certainly to my mind, it's actually quite concerning that due to not necessarily staff having COVID, but being told to isolate, we're relying on members of the military to fill a civilian role, and it seems that whenever anything seems to hit the fan, proverbial fan, we call them in. Now, we can do that for so long, but they've obviously, as you can appreciate, got the day job, as it were, to deal with.
Thank you, Chairman. Yes, I understand the military personnel that joined the East Midlands Ambulance Service were given familiarity training last week, and I think, as it says in the statement, 14 Royal Marine Commandos are based in the Lincolnshire division, and they would be actually fulfilling their roles as of this week. So that is an ongoing thing. I expect it would probably continue, but it may be something when the East Midlands Ambulance Service are presenting at this committee next month for a question to be raised on whether that is still continuing. Thank you, Chairman.
Thank you, Simon. And I would say that obviously, you know, we would welcome them obviously helping us out. I think it is very unusual circumstances, and if it alleviates some of the pressure on our trust and the ambulance service, then it is incredibly welcome. Councillor Allen first, please.
Thank you, Chairman. It's a sort of follow-up to the question that Councillor Smith raised. Does the requirement to have the military involved, and I welcome the comments that you made about the support is going to be excellent if and when it's required, as it seems to be. But does it take into account the latest rules on self-isolation? Because the issue about having the military involved is to do with the current transmission of the Omicron virus and the need to self-isolate. But that has changed quite recently, I think, or changed twice quite recently, and we're now into a fairly short period of time before people are able to go back. So is there a difference between what the government rules are and what local rules are that are applying, which puts more pressure on the need for the military support? And is the time period associated with why this might be required likely to change, or can only change as governments make new arrangements in terms of the amount of time that self-isolation is required?
Simon, you'd like to respond on this one?
Thank you, Chairman. I can't give full answers to those questions, given that the announcement was made on the 11th of January by the East Midlands Ambulance Service. I think we would expect that the discussions were taking place certainly in the first week of January, between the ambulance service and the Ministry of Defence and the armed forces. But yes, circumstances have changed in the last week or so, and certainly the period of self-isolation the limits have changed. And once again, I have to say it may be something for the committee to raise with EMAS when they're presenting at the committee next month. Thank you.
Thank you, Simon. Yeah, Simon said, I think at the moment in time, We have got a presentation coming up from EMS, and perhaps we'll just have to wait and see what the outcome is. I think, as I say, you know, I think they'll be there as long as they're needed, I think is probably the reasoning behind it. And I think if it does help the situation we're in, it's very welcome. So thank you. Councillor Whittington. Okay, I've got Councillor Wootton next, please.
Thank you, Chairman. I mean, this is not unusual because if you cast your mind back to 1989, when I served in Bedfordshire Police, we took over the ambulance role because there was a strike on for quite a long time over a pay dispute there. So it's not an unusual case. In fact, we were on patrol just with transit vans and a basic medical kit taken over from the ambulance service for quite a few weeks.
Thank you for that, Councillor Wootton. I've got Councillor Thompson next, please.
Thank you, Chairman. Just a reminder, within my living memory, the NHS were asked to support the Ministry of Defence in one of the Gulf Wars, and actually it is of mutual benefit in terms of the military supporting the NHS from a training point of view. So I think that's actually quite, there is a degree of sharing of the services. Thank you.
Thank you, Councillor Thompson. I think that's very useful. Councillor Harrison.
Thank you, Chairman. I'd like to just ask about the Chairman's announcement attached to the agenda as item 4 and page 14, section D at the bottom. There's a lot in that paragraph, but it doesn't really explain how that's going to be done. I wondered if in the future we could ask for more clarification, because it says 5,000 extra beds. Yeah, it gives some reference to virtual ward models, etc., but it's not really very helpful to us at the moment. Thank you.
Simon.
Yes, I think it may be worth, the answers may be in the full document. So I've provided, just lifted out the priorities, and I apologise if the summary is too short. But yeah, that is a good, certainly that 5,000 additional beds is something that it needs perhaps further information. But I've made a note of that. Thank you.
Thank you. I don't think I've had anyone else indicate. So in which case, I would like to take a proposal that the Chairman's announcements and supplementary announcements would be noted. Do I have a proposer for those, please? Councillor Smith, thank you. And do I have a seconder, please? Councillor Scalisi, thank you. All those in favour, please show. Thank you. They're supported. In which case, I'd now like to move into agenda item, excuse me, just 1 minute. It'll be agenda item 5 momentarily, but I'm just going to take the questions, meeting and conduct. Before we move into the substantive part of the meeting, I would like to ask that you keep your questions and contributions succinct and concise, ideally no more than 2 questions per person per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. In which case, I'd now like to move into agenda item 5, Lakeside Medical Practice, Stanford Lessons Learnt. You'll find this on pages 17 to 28 of the agenda pack, and the focus of this item is the lessons learned from the events at Lakeside Healthcare in Stanford. Therefore, I would urge the committee to focus on the general issues, in particular the progress with the recommendations in Appendix 1, rather than the specific issues relating to Lakeside Healthcare. I'd now like to welcome our presenters via Teams from the Lincolnshire Clinical Commissioning Group, and that is Sarah Jane Mills, Chief Operating Officer for the West Locality, Wendy Martin, Associate Director of Nursing and Quality, Nick Blake, Head of Transformation and Delivery for the South Locality, and I'll hand over to you for a quick run through the report, please, ideally 10 to 15 minutes, and questions at the end. Thank you.
Thank you, Chair. Just to introduce myself, I'm Nick Blake, Head of Transformation and Delivery. Sarah Jane sends her apologies, Chair, as well, and wasn't able to make the meeting, so myself and Wendy will cover the item if that's okay. In terms of the report, I won't go through it line by line, but just to give an overview, the report really focuses in on the events leading up to Lakeside exercising the break clause on their lease, goes through some of the planning work, looking at alternative primary care sites in Stanford, particularly on the Stanford Hospital site, and some of the process and discussions with stakeholders around that. And then goes into some of the issues around the lease as a result of that, with Lakeside serving notice, and then there being some time pressures on organising an extension to that lease that led up to the announcement by Lakeside to the public that they were intending to close down the St Mary's site, and in the process to review that and take that to the Primary Care Commissioning Committee for a decision in November 2020. As the committee will be aware, in the end, an extension of the St Mary's site was agreed with the landlords, and the site remains open to this day. So that decision to close St Mary's site was in fact set aside at that point. Currently, the position for delivery at St Mary's site is that a full range of primary care services are being delivered there. I think the only exception to that is that some ECG diagnostic work is only carried out on the Sheep Market site, but apart from that, there's a full range of services, so GP appointments, dispensary, nurse clinics, etc., run from St Mary's site. As the chair pointed out, the report itself really focuses on the process, the CCG's decisions, and how the CCG managed the discussions with Lakeside and stakeholders. And there are a number of particular points that came out of that review that the CCG has reviewed and has made some recommendations in terms of how it better manages similar situations in future. I'd just like to give a short update on that, if I may. So one of the things that had been picked up was around contract management with primary care contractors. And the recommendation that there needs to be clear roles and responsibilities defined across CCG teams. There's been progress on that. At the moment, there's a primary care commissioning team reorganisation, and we are organising ourselves to manage primary care contracts commissioning across the whole county. Also, there's been a slight reorganisation of the contracting team, and we have named contacts who work with us on the primary care contracting within the CCG contracting team, within our commissioning support unit as well, Arden Gem. So we have named contacts with clear responsibilities. Alongside that, there's been discussions with the NHSE regional primary care contracting team, and we've agreed the roles and the boundaries between what the CCG does and the NHSE team provide as well. That will be changing in future as we move into an integrated care board as well, and we'll carry on reviewing that. But I think overall what I wanted to say around contract management is there's much clearer roles and definition of who does what, which means that all issues around primary care contract management will be picked up and managed appropriately in future. One of the other things that I picked up, and I think it's related particularly to some of the discussions around the potential development of a new primary care site in Stanford, and the management of that programme of work with a range of, became quite a complex programme. What has been developed in the meantime is a primary care programme management approach. So we've got a new way of managing complex programmes of work, which includes things like stakeholder management and a new kind of more structured programme management discipline, which I think will mean that some of the issues that came up through the start of those discussions and that review of the options to develop a new primary care site will be avoided in future and managed effectively. Linking into contract and programme management, one of the points we raised was around estates management. So one of the recommendations was around estates management, looking at things like being aware of when lease breaks were coming up, and any risks and issues around estates across the primary care portfolio. The primary care team has set up an estates group now, so that group is charged with overseeing all the primary care estates at the practice level, but also at the primary care network level. And they'll be managing all risks and issues around that. And at the moment, are in the process of working with an external provider, CHP, who are carrying out a data collection exercise on all leases and all estates. And they're working with primary care to oversee all. They're working with primary care to understand the position around estates, any pressures around capacity, etc., and we'll be reporting that through to the estates working group and providing a database that will allow ongoing monitoring of estates issues in future across the county. The estates group meets on a monthly basis and overseeing and monitoring all risks and issues in relating to estates. And is also working with CHP and practices to develop a estate strategy as well. So the CCG insisting to be assured that primary care estates is fit for purpose and also supports the ongoing direction in terms of clinical strategy and delivery of primary care services. I think the other thing just to point out, and then I'll stop for a moment, is that we're also reorganising how we monitor primary care delivery and quality assurance. So there's been systems in place across throughout the time the CCG's been in place, of course, but we have reviewed how primary care quality assurance works, and a range of meetings have been set up with reports looking at a range of metrics so the CCG can assure itself of primary care delivery in terms of quality, activity, etc. So things like access to primary care will be picked up through those forums as well. And I think that will strengthen the CCG's view on primary care delivery and primary care quality. I think, again, that will address some of the issues that were picked up through the lessons learned report. I'll pause now, if I may. I'm very happy to take any questions or comments, of course.
Okay, thank you. I'll start with Councillor Whittington first, please.
Yes, thank you, Mr. Chairman. Thanks for the report. My question fundamentally is around the sort of Appendix 1, where we've got the lessons learned from what happened, and it's been broken down, you know, category, description, impact analysis, recommendations. What it doesn't have in there is a timetable as to when these recommendations are likely to be implemented, and potentially sort of another column, you know, that would indicate have there been any problems in implementing the recommendations. So that would be my first question. Would it be possible to show that information? You know, is there an agreed time frame within the CCG for implementing these recommendations? And secondly, within the internal organisations of the CCG, who will be sort of monitoring progress against this? Because, you know, if this was a local authority similar report, it would almost certainly be the local authority's governance and or audit committee that would, you know, be responsible for monitoring progress in terms of implementation of the recommendations. So a bit of clarity around both those two questions, Mr. Chairman, will be very useful. Thank you very much.
Thank you, Councillor Whittington. So for the answer to your first question is yes, I'm certainly very happy to provide an updated version of that table with a column showing progress and timelines against those actions. Some of them we've completed already, but I can update the table and provide that to the committee. In terms of oversight, fundamentally or ultimately, that would be the Primary Care Commissioning Committee, which is responsible for primary care commissioning. We're in the process of setting up a primary care steering group, which will look at the nuts and bolts of delivering those actions and making sure that those are delivered in a timely manner as well, and we'll report up to the Primary Care Commissioning Committee. But again, very happy to provide kind of a summary of that as part of an update to that table too, if that would help.
Thank you for the response, and Councillor Whittington, thank you for the question. Councillor Cleaver.
Thank you. I'd like to thank the officers of the CCG who've been dealing with this over 2 years, and thank them for their help in answering my questions during that time. I'm now glad to see this report. I have to say that I'm not completely convinced that the same issue couldn't arise again as a result of this, and I look for reassurance on that. The fact is that a large commercially forceful partnership of 71 doctors exercised a break clause in their lease on the premises in which they were contracted to deliver NHS services without the permission of the CCG. And they did so in a time span where it would have been impossible to have built a new surgery, to have acquired a premises, gone through the design phase, got planning permission, and built it. Now, that implies to me that there was a clear intention to force the CCG's hand. And I think that's morally indefensible, frankly. In response to that, I would have assumed that reviewing the contractual terms and conditions which apply in such cases, you would consider putting in a penalty clause which says, if you surrender the lease on the premises in which you are contracted to deliver NHS services without our permission, there is an automatic multi-thousand-pound penalty clause, end of. And I'd like your response to that. And also, can I just ask, as merely a matter of interest, it says the paper was shared with the CCG's internal auditors. I wonder why that was and what their comments and observations were, just as a matter of interest. Nothing. Thank you.
Thank you, Councillor Cleaver. In response, I think the work of the Estates Group and some of the systems that the CCG are putting in place, I think, will mitigate the risk of this happening in future. I don't think it's always possible. It's impossible. I don't think it'd be possible to put in a completely foolproof system. There may be some issues that we can't foresee, but I think the systems we're putting in place are a good approach to managing this and really do mitigate any risk of practice serving notice about the CCG's knowledge in future. I think purely having the database in place where we can keep we can track all leases, break clauses, etc. And the fact that we're engaging more closely with primary care across the patch due to the new primary care team setup, I think will mitigate a lot of the risk around that as well. Just to pick up the point around penalty clauses, the contract that practices or primary care providers have is set nationally, so that's something that we're given. We can't alter that or change that. But certainly, I think the CCG wants to take a robust but proportionate approach to contract management, and certainly will be, as learned a lesson, I think, from the experience with Lakeside, ensuring that practices are very clear about the CCG's approach, and that we're clear that any moves to end provision at an existing site would be breach of contract. And again, that's something that we were, as soon as we were aware of the position with Lakeside, we were very clear with them on. So I think that's the other answer to the other question. I think the final point you were asking about was the internal auditors and their view. We were guided by Primary Care Commissioning Committee just to talk to PricewaterhouseCoopers because of their expertise around internal audits and carrying out similar kinds of reviews. So they provided really just sort of guidance and a steer on the areas we should focus on, and also the how we presented the actions, or how we considered the actions that needed to be taken. Those presented those back to PC3. So it's very much a kind of an advisory capacity, and they didn't get involved in the content, but really the sort of structure of the report, and making sure that we picked out the key issues from the sequence of events. Again, I don't have the detail to hand again in terms of the feedback they provided, but it was very much around structure and how the lessons learned were presented back to PC3.
Thank you for that. In terms of what you said about the CCG's improving the way it reviews quality in the primary care sector, I welcome that, and I hope that we'll be able as a committee to take that on board and review that at the same time as we review the next CQC inspection report for Lakeside, which I gather is in our programme of work. Thank you.
Thank you, Councillor Cleaver. I've got Councillor Smith next, please.
Thank you. Excuse me. Thank you, Chairman. In the report, part of the reasons for the issues at Lakeside, it mentions the lack of codified documentation outlining the provider's obligations, its powers and its limits on those powers. From the lessons learned report, what steps have been taken so that this issue has been resolved, not just here, but so that it can't arise again within Lincolnshire CCG? And also, on a slightly different tact, how has working with NHS improvement around contractual management assisted since the lessons learned report? Because I'd be very interested to know. Thank you, Chairman.
Thank you. In terms of being clear with practices, Obviously the contract documentation sets out the requirements and responsibilities of the primary care providers. What we're doing is having ongoing engagement with all practices, and we have through the reorganisation of the primary care team, we moved from 4 CCG localities, which we still maintain and work on a locality level, but we have a kind of an integrated primary care team that covers the whole county now. We have locality managers for each locality who stay in direct contact with practices and pick up issues as they come up. What we will be doing is, as issues around contractual issues come up, those locality managers will be liaising with our contracting team, the commissioning support units, and also the CCG's contracting team, to make sure that we can advise practices. And I think the key thing really is ongoing and proactive engagement with practices. The other side to it as well is something I've referred to as around the estates groups, where we're aware that there are risks or issues or potential lease breakpoints, or leases are reaching term. We pick those up proactively and work with practices on that. There is a guidance manual around contractual issues and gives guidance on the NHS primary care contracts as well, which is available to us and also available to practice. And we use that really to provide guidance to practice on the nature and the detail of their contracts. We can also get guidance from NHS England as well. And I think just picking at the second point, the NHS England regional team have had a significant role in contract management previously, but those functions have been delegated to the CCG over time. The point we got to in 2020 was where we agreed a memorandum of understanding with NHSE. So we defined what the NHSE regional team would and wouldn't do, and what functions had been passed over to the CCG. So really just clarified that. The majority of commissioning contracting functions have now been delegated to the CCG, with GMAS picking up. GMAS, is the regional contracting team, picking up some administrative issues, so managing things like where there is a change of partner of the GP practice, they'll manage the paperwork around that, and CCG will sign that off. So again, GMAS, the NHSE regional team, really now providing a more of an administrative function, but that's now set up in the memorandum of understanding, so very clear who does what. So I hope that answers the question, but please do follow up if not.
Councillor Smith, you'd like to come back?
Thank you, Chairman. Around the contractual side, that's very welcome, and there's clear, shall I say, steps that have been taken to mitigate the issue. Whilst it's welcome, there's more engagement with partners on the ground, be they the doctors' practices and care in the community, etc. How is that? How do you measure the success of that? Because it's very difficult to measure. Yes, you can do it, but how do you know it's working? And how can we, as the chair said, effective scrutineers, how can we scrutinise its effectiveness? Because it's a very it's very much a matter of opinion how effective engagement is or isn't.
It is a good point, Councillor Smith. Yeah, and it's a tricky one to understand engagement. How do we quantify engagement? We can have a range of dashboards that we use, and probably wouldn't be helpful if we shared all of them. It goes into too much detail and some are very specific, but we do have we are developing a range of quality metrics, and we do have what we are doing is standardising quality reports across primary care. With the 4 localities, we had slightly different approaches to quality assurance around GP practice in the past, and we are, as we come together as one team, we are bringing that together and taking a consistent approach now. We are carrying on having locality quality assurance meetings, so we can get into the detail and the granularity of what's going on at practices. But then those are feeding up to a county-wide quality assurance meeting, where we look at kind of some of the high risk or practices where issues need to be escalated. There's a range, so we have a range of quality reports that support those discussions, and again, we could look to share some of those or some of the detail around those and how we approach that. We also have other dashboards as well, which the primary care team use, that track and look at various metrics or RAG ratings around engagement, staff capacity, whether staff have been vaccinated, etc. Things like that. So again, I feel I'm in danger of getting into a bit of a ramble, so I will cut my response short. But we do have a range of dashboards and metrics where we measure this. In terms of engagement, I think it's a little bit of a subjective measure, and the locality managers and the primary care team commissioners will have a view, and quality colleagues as well will have a view on how well we're engaged with practices, how do they respond to our requests, etc. But something that we don't necessarily quantify, but maybe that's something we could look into.
Thank you. I don't know if anyone else is struggling to hear, but it is becoming a sort of ongoing issue, I think, at every meeting now, and I think we'll certainly all welcome it when our NHS colleagues can return to the chamber, because I think it is, in some respects, having an effect on debate, really, and trying to get a robust answer is not always overly helpful in the current circumstances. Councillor Allen, I have you next.
Thank you, Chairman. Yes, I welcome your comment about getting back to proper committees and people being here, so that we don't have these problems. The concern I have is that we know, I think, to a certain extent, that the contracts that operate within the primary care are not always visible or transparent in terms of what it is that they actually contain. Never mind whether they contain any form of remedial action that you can actually, that should actually be normal contracts if performance isn't what is required. And it is very difficult to do an awful lot in terms of actually ensuring that alterations in terms of provision do take place, because what can we do at the end of the day? Can we close a practice down, because that's not likely to be very successful or very acceptable to the public. But it does make it quite difficult, I think, then to actually put any pressure on practices in the primary care, and the bigger the practices, it seems to be even more difficult to actually do. Something I think really does need to be done, but it is probably something that's beyond this committee and beyond this county, I think. So it's whether comments at the end of the day are going back to where they ought to be going back, to Westminster and London, saying something has to be done here because it's just not really working very well. COVID has highlighted some of the concerns, I think, that probably existed before. And our exit to COVID is probably going to be equally illustrative, I think, in terms of what the issues are. So I'm not asking really for any response. I'm just saying perhaps it needs to, go further afield.
Thank you, Councillor. And I don't know if you've got any form of response to that, Nick.
I think there's always opportunities to improve contracting and how services are commissioned, and there's a kind of a process and a cycle of that happens. So I guess there are opportunities to feed back to the centre about that. I think just one thing I wanted to say was, although there are potential areas for improvement in primary care contracts, I think they also provide flexibility, and without wanting to sound overly defensive, I think primary care have done a fantastic job delivering COVID vaccinations as one example, and they've been able to do that due to the way they can work flexibly and change their delivery really very quickly, delivery models really very quickly to support the vaccination programme. So I take on aboard the points the council makes. I think there are opportunities to feed in. I think it's important to take a balanced view on how primary care has performed overall over the last couple of years.
Yeah, thank you for that. I don't know if it's on your end, Nick, or on our end, but all of a sudden it became a lot clearer, so thank you. I've got 3 questions for you, if I may. So my first question is, on page 26, under the category reinstatement of primary care services, can you expand on which services Lakeside have been or are being reinstated, and has the CCG now received full clarification of these?
Yes, thank you, Councillor. So that was the reinstatement of the core range of primary care services at the St Mary's site. Those services have been reinstated, and I think I mentioned earlier in the presentation, the only exception to that, although it's not a core service, the only service that Lakeside provide that isn't being provided at St Mary's is electrocardiogram diagnostic tests. which are happening at new sheet markets. So anybody requiring an ECG would be directed to new sheet markets. Otherwise, people can go to St Mary's to receive primary care.
Okay, thank you. My second question is, the recommendations have been in place for 3 months or so. How is progress going, which I think has been touched upon in part, but not in full?
Just to clarify, that's progress with the recommendations from the lessons learned report.
It is, that's correct.
Yeah. So progress is going well. I've tried to cover a couple of the points in my response to the questions, but in terms of primary care team reorganisation, development of clearer relationships with the CCG's contracting teams, also with NHS England contracting, the development of the primary care estates group, and the improvements made around quality assurance within the CCG. A number of those recommendations have been completed, or at least there's been very good progress on them. Just to pick up one of the early questions, I'm more than happy to provide a revised table with some commentary on progress and timelines and all of those actions, if that would help.
Yes, thank you. That'd be very helpful. My final question is, can the committee be reassured that the Lincolnshire ICS, due to be in place from the 1st of July 2022, will continue with these recommendations?
Yes, so the ICS will be coming into effect, obviously, this year, but the primary care team is remaining the same, certainly in the short term, as far as I'm aware. We'll be carrying on to deliver and make sure all those recommendations are delivered and completed.
Okay, thank you. In which case, I'm going to propose that we endorse the recommendations as set out in Appendix 1 to the Lessons Learned report, to look forward to their further implementation and to seek further advice on the recommendations and timeframes for them. Do I have a seconder for my proposal? Councillor Lundwatson, thank you for seconding that. All those in favour, please show. Thank you, that's fully supported. And I'd just like to thank Nick for his presentation. I think Wendy dropped out, but thank you for your time.
Thank you.
In which case, I'd like to move on to agenda item 6, Sustainability and Transformation Partnership, the Clinical Care Portal. This can be found on pages 29 to 34 of the agenda pack, and our presenter via team from Lincolnshire County Council's Adult Care and Community Wellbeing are Theo Jarrett, Head of Quality and Information, and Samantha Francis, Information and Systems Manager. Can I hand over to you just for a brief run through, please? Thank you. Not okay, thank you. Okay, so we're just waiting with sort of 5 minutes or so. I think they were expected for about 11:15. So if anyone wants to just nip and have a coffee, that's fine, but as long as you're back relatively quickly. will just point out the schedule's sort of not going to be as in sync as it would normally be today, because urology did drop off of the agenda due to the fact ULHD are obviously under quite immense pressure and asked if they could present next month instead. So if we do run a bit early with things or late, that's the reasoning behind this one, I'm afraid. We're just waiting on one more speaker and we will then begin agenda item 6. Okay, fantastic. I think we have our speakers now. So once again, I'd like to welcome Theo Jarrett, Head of Quality and Information, and Samantha Francis, Information and Systems Manager. If I can hand over to you just to run through the report, and we'll take questions at the end, please. Thank you.
Okay, thank you. That was good timing. My job title has been introduced there, but just to give a little bit of an overview. So I'm responsible within adult care and community wellbeing for the Directorate's approach to using technology in care and wellbeing and care and support. And it's a program that we've had going for probably about 4 years, and it's really about how we can best use technology to enable people to get to the right care and support. What we've got is a series of projects and initiative based around 3 themes. That is digital customer or digital citizen. That is where individuals can use technology or access services remotely. if they have the means to do so, and that's very important. Secondly, digital workforce, where we are trying to give our workforce, both internal to the council and external to the council, the tools they need to do the job effectively. And the third area is digital community. So this is a selection of projects and initiatives that we've been working on with partners and with social care providers to really try and knit together and provide that backbone to integration of health and care services. So it's that area, that theme, where this particular project lies in terms of our strategic approach. So the care portal is something that I think is seen across Lincolnshire in health and care organisations as a cornerstone of a lot of what we want to do, supporting that integration, making sure that services can work more effectively with each other. Information is shared appropriately with the appropriate staff and with the appropriate services to ensure patient safety and also effective use of resources. So it really is seen as the way forward for what we want to do. Samantha's been leading on this for the council, working with colleagues across the NHS to get it to the stage where it is today. And I think it's fair to say it's a really positive picture, certainly viewed from the NHS point of view to the council in terms of the fact that we're on board and we're really pushing hard with this. So what I want to do is hand over to Samantha now, who could take you through more of the detail of what it is exactly that we're talking about and how it fits in with what sort of benefits it has for our staff and also patients and citizens in the county.
Thank you very much. Thank you, Chairman, and thank you, Theo. Just to cover the key points of the report that we've brought to you today, you'll see from the report that the care portal, as Theo has touched on there, enables organisations to share patient data. It means that our different source systems across both health and care can be presented in one really easy to use window and format for our staff to be able to see. And it gives a holistic picture of the view of somebody's patient health and social care record. The intention is that it will evolve over time. At the moment, there are certain source systems that are included on the care portal and others that are in progress, which our STP colleagues are working on. But eventually it will include hospital data, ambulance service, LPFT, as well as our own and potentially sort of third-party sector information as well. In terms of LCC's involvement so far, it's been a long time coming, but we've got there in terms of technical capabilities. So the first phase has already gone live. We have health data viewable via Mosaic. So our social care staff can access a person's record via Mosaic and enable them to see an agreed data set from the health record systems on their Mosaic record. That's already in play. We have just over 800 users in total in terms of worker roles on Mosaic that can access that data. We have just over sort of 400 frontline staff accessing that on a regular basis, and you'll see from the attached data in the appendices, we're getting sort of 250 to 300 weekly visits from our social care staff actually using that data. So, and the feedback again in the appendices indicates that our staff are finding it really useful to be able to see that wider picture of health data from the care portal that they wouldn't normally be able to see via the social care access. And would have to potentially previously ask health colleagues directly, emails, telephone calls, paper files to be shared. But at this stage, it means that, and moving forwards, it means that patient data will be more readily available in an accurate and timely fashion for our social care staff. The phase 2 work that we're doing at the moment is development and testing stage. So that is the flip side, which is our social care data displaying in the portal for our health colleagues to be able to view. Again, we've agreed a initial data set that will be shared from the social care mosaic system. And the way that will view is a tab within the care portal for our staff to be able to view it across the health organisations. You'll note from the report as well, we also have a pilot ongoing in terms of shared care planning. So our hospital social care teams are currently involved across the Lincoln and Pilgrim sites to be able to do shared care planning, and that's actually inputting to shared care plans with health colleagues as well in a number of wards across those two health settings. I won't go through all of the details in terms of the benefits from the report, but I'm sure you can understand that it will be of great benefit for both our health and social care staff to be able to have that better holistic view. And as I say, it's timely, accurate, up to date. It updates in real time. And it means that both our health and social care staff will have wider access to data that they previously wouldn't have had access to readily. Organisations with access to the portal at the moment, for those of you who may be interested in this, we have primary care, LCHS, ULHT, LPFT, neighbourhood teams and LCC, as we've mentioned. And at the moment, there are a number of data sources, but as I've said, STP colleagues are working on being able to add further organisation sources from different source systems. Currently, ULHT, GP Connect, EMAS and our regional colleagues at Peterborough, Stanford and Rutland hospitals, their data is displaying for staff that have access to the care portal. The next data sources that our STP colleagues are developing is, as I say, our data set from Mosaic. That's hopefully going to be in the next month or so, and working with colleagues from LCHS, LPFT, and then colleagues within the health settings in maternity and endoscopy are going to be the next ones on the roadmap for them. I've also noted in the report for you that the future portal development programme does intend to include a patient portal. So at the moment, the information that's available is purely for clinical and partner professionals to access. But the intention is that there will be a patient accessible record, which will mean a data set of the patient's record will be readily available for them to be able to view and potentially to be able to interact with their health professionals and their care professionals through that platform. The intention is that hopefully we can have wearable devices and monitoring devices, OBS devices, to be able to provide integrated data into the portal for health professionals to be able to access, and also some analytics information across, so that all organisations can access that analytics for the data as well. I think that's the key points from the report that I wanted to share with you today, so I'll open it up to if there's any questions.
Okay, thank you. Yeah, the first question is from Councillor.
Thanks, Carl. I've got no objections to it at all on principle, and I think it's sensible and it seems well thought out, and I hope that the governance is tight around that data. But my question is a bit of a kind of a question about the burden of knowledge on our social care staff. Because how well versed are they in those medical conditions that might actually be quite complex and profound in terms of then making judgment calls about people's care. So really it's kind of, how does that change? How does that shape then that frontline delivery that those staff give that patient? Or is it just a case of being able to have the context and the understanding as you go in and have those discussions? Is it allowing them to develop better care on the front line?
Theo, did you want to mention anything there, or?
Yeah, I'll just briefly mention something there. I suppose it's what we're looking at is a situation, probably the latter description that you mentioned there, Councillor, where it's enabling that wider view of the individual, the role that social workers and also care workers employed by the council would not change at all. It's allowing that holistic view. I think what we can do is look at what would have happened previously, where we've got situations where people might come out of hospital on different medication, and the information about what medication that person is on, when it should be administered, what sort of side effects or maybe behaviours might be expected from that individual might have come out in a letter, and it would have come out. We've done some analysis of the information flow. Sometimes it was up to a week, 2 weeks later. So you had care staff working, social workers working with the individual, trying to understand how that impacted on their care without the full information. So I think just in summary from me, before Sam's able to come in, is it won't change the role of the care worker or social care practitioner, but it will give that wider, more holistic view of the individual that is, as Sam said, it's real time, and it allows the right care to be given. And the access to that information is entirely governed appropriately to the right care staff. Yeah, Sam, I don't know if you want to add anything to that.
Yes, Councillor, what I wanted to mention was in relation to both your comment about governance and about this as well. We have a regular clinical reference group that is held between our the partners that are all stakeholders within the portal. And within that clinical reference group, we are regularly reviewing the data that gets shared across the different organisations. And one of the key things I was really keen on making sure that we considered when we started to have access for our social care staff was that they were fully aware of what it was that they were going to be provided with, and that we also made sure that as the data was presented on the portal via Mosaic, there wasn't a sort of plethora of jargon and codes and things that would pull out of those source health systems, because as we know, different systems use different ways of recording those things. And whilst a health practitioner might understand those SNOMED codes and the different codes that are used within the health systems, as you said, social care staff may not understand all of the information that's being presented to them. So we've made it very a high level item on the agenda for those clinical reference groups to actually talk about what presents, that it doesn't present in jargon and codes, and that we go back and speak to our social care staff now that they've had the system in place since February last year, that we actually talk to them about the information they can see on the system. Is it useful? Is it readable? Is it understandable? And is there anything that actually from their point of view is missing at the moment that they would hope to be able to see from health colleagues and the patient record that actually would be useful for them in their day-to-day workings with social care service users. So we are very aware that we want to make sure that there isn't that massive gap in terms of understanding across social care staff and health information that's coming through, but definitely there isn't a requirement to do any more from their point of view at the moment with the view only access. It is just to enhance the information that they're already having, either through discussions with the service user and their families, or the discussions that would be ongoing with health professionals anyway. It doesn't replace those ongoing conversations and that ongoing kind of learning from our health colleagues. It's designed to enhance that. So I hope that answers your question.
Yeah, it does. It's really helpful because I think the concern would be almost too much information on the jargon and all the rest of it. So that's really helpful. Have you found that in terms of social care staff, it's identified areas of training for them where there's been a plethora of information and you've got a significant cohort of staff who are then coming back and saying, tell me more about this, how do we help in this situation?
Thank you, Councillor. I think that's something that I want to explore more with our staff now that they've had it in place for a while. The initial feedback that we've had, some of which I've included in the report, is very kind of anecdotal at this stage as to the benefits that they found from using it in being able to sort of help with multidisciplinary conversations and best decisions discussions. But that's definitely something that I want to explore with them more, is whilst it's probably enhanced their understanding of what's going on with a patient or a service user, actually, is there anything that they need more support with now that they have access to that wider range of data? So yes, that's something that's on the to-do list.
Okay, thank you.
Just from my own point of view, I was hoping for a bit of clarification. I noticed that you mentioned data sharing with ULHT. I was of the belief they still work with paper records. So has that now changed, or is there a different way in which they do share that data?
From my understanding, there is information that they are recording on electronic systems, and that's the information that's being shared through the portal. There may be paper systems still in place in some areas within ULHT, but this in particular is as you'd expect, sharing that electronic data that's being recorded on their internal systems. I'm afraid I don't know much more detail than that.
Okay, thank you. I've got Councillor Whittington next, please.
Thanks, Mr. Chairman. I did have several questions, and one of them actually was around paper records or the assurance that all the health records of individuals are actually available in a digital format, because obviously, you know, if you've got any patient who's sort of long-standing over numerous decades, are going to have paper records going back from maybe from the 50s, 60s, 70s onwards, so even in some cases the 30s and 40s. Obviously, pretty much all those are going to be in sort of paper format. I'm just wondering, which then leads on to my second question, was how can we be certain that all the data that's on there is complete? Was a review of the data done before the two systems were actually merged? Because you work on the whole basis of, you know, a system is only as good as the information that's fed into it. If the information that's fed in is incorrect or incomplete, then you're not really going to get a sort of, you know, a full picture at the end of the day. So I'm just wondering what sort of, you know, just a bit more clarity around this paper records. Were the records complete? Was there any sort of review done of the data to make sure it was complete? Because on the, you know, before the systems were merged. And then that then leads on to, when you are starting to implement these systems for a certain while, it's probably advisable to have a system of double running, where you run the two systems alongside each other to sort of, in effect, make sure that the data is still being picked up correctly. So I'm just wondering if that happened. It's just really around the process of how the two systems were merged to sort of spot these issues, because obviously, if things have been left off a patient's records, that, you know, that might then potentially change a diagnosis or a course of action that somebody might be wanting to take. So there's that kind of post-implementation review as well that I'd be interested in. I mean, that may still be an ongoing process, but just some clarity around how that is going to be sort of monitored, you know, just to make sure that, you know, these records are complete. Because I fully support the idea, and if we're moving towards an integrated care system, and, you know, greater working between the NHS and adult social care, which has got to be welcome, because the whole point of this is trying to identify issues before they become serious. You know, the whole basis of early intervention to catch people, you know, down, you know, upstream, as it were, before their conditions become really serious. But obviously that then depends upon the information being correct and accurate. So just some more clarity around that, I think, would be really useful. And then just something on this in terms of GDPR. I'm presuming all this stuff is GDPR compliant. And again, just a bit of clarity and around that, I think, would be useful. Thanks, Mr. Chairman.
Okay, Sam, if I can just come in there first, just briefly on the so we're talking just on the point of digitisation of processes and records in health partners. I think it's probably important to point out that the care portal, although it is that interface between health and social care, it is equally an interface between different health departments and different health systems. I think have been told, but I can't remember off the top of my head how many different systems ULHT have operating at any one time. Some of them may still be paper-based. I think there is a program of digitisation, but it's dozens and dozens. It may even run into the hundreds for different specialties and different departments. So I think the care portal acts as that window from one system to other systems, just as it does from health in general into social care. Our Mosaic system, just as other health systems, is subject to data quality, governance, usage, audits about complete records, and there's an ongoing program of ensuring that records are audited, checked, make sure that they fulfil the right level of data quality to ensure that it's up to date and it's complete. And likewise, that is the case with health colleagues. So when staff come to view records through the care portal, and it might be just certain elements that they're viewing, dependent on their access, and that is right to pick up in terms of appropriate access to different staff groups and different roles. There is some reassurance that we are viewing the most complete record that is available for that person. Sam, I don't know if you want to come in on more of the detail on that.
Yes, thank you. And thank you, Councillor. Yes, in terms of paper records from a health point of view, my background is in the social care side for the council, so I'd have to go back to my colleagues in the STP as to the original requirements and the governance around the paper records. And as Theo said, I believe there is a programme of digitising historical paper records in the health system, because as you've mentioned, there are probably thousands, if not more, paper files and things in various different locations. So I believe that is part of their overall digital transformation programme, is to digitise those records. From a social care point of view, we have all of our health, social care records on the Mosaic system, and historical data is included on that. So yes, that's something that I'd have to probably come back to the committee with from health colleagues on the digitisation of paper records. And again, asking them the question that you've mentioned there about post-implementation review, on what their intention is around that ongoing kind of review and checking of the data that's being recorded and shared. From a GDPR point of view, in terms of compliance, information governance and information assurance colleagues have been involved all the way through the Care Portal project, and they have a regular meeting to talk about the various different digital projects that health and care are involved in, and Care Portal is one of those on the agenda in terms of making sure that every time a new source system comes on board, there are the relevant and required DPIAs and GDPR compliance documentation in place, and information sharing agreements as well across the different organisations as to what, how and why we are sharing that data. From a social care point of view, our statutory duty enables us to have that information shared without explicit consent from our users. Health have a process in place in terms of opting in and opting out of the portal. I believe that's still the case for health colleagues. So every time a new cohort of users in the community of information is shared, dependent on the source system that's coming through onto the portal, those users are made aware that their data is being shared, and the ins and outs of what that data is and why it's being shared and who it's being shared with. We also, on our side, as well as the information sharing agreements and data protection assessments that have been done, we're also making sure that information is clear on our privacy notices for our adult care social service users as well. I hope that answers the questions that you had.
Okay, thank you for that. In which case I've now got Councillor Cleaver, please.
Thank you. Just a couple of questions. I noticed that East Midlands Ambulance Service is a data provider to the system. but currently doesn't have access to the portal. Is that because the ambulance service has access to patient records through another route when they're on the way to a call or when they have a patient in an ambulance? If not, is this service going to provide that at some point in the future? And in relation to primary care data, again, I noticed primary care have access to the system, but are all primary care providers mandated to share their data, or is it voluntary? And if it is voluntary, what percentage have actually volunteered to share their data, please? Thank you.
Thank you. In terms of the EMAS information, that was shared quite recently, just before Christmas, in terms of the data that they're sharing. And I believe it's a couple of their documentation forms that they fill in when they're doing the referrals into hospital settings. Again, I'm not close enough to the health side of things to be able to advise as to when on the roadmap they intend to have direct access to the portal, if at all. But that's something I can take back to my STP colleagues. But I do believe the comment that you made about them having access to that information via other health systems is correct. I think they have access via their other health systems to be able to see that information. But obviously that wouldn't necessarily include things like our social care data as it surfaced on the system. So I will be checking with my STP colleagues as to whether EMAS as a system to be added for access to the system is on their roadmap or not. In terms of primary care, the mandatory versus non-mandatory sharing of data on the system, that's conversations that I believe are ongoing with STP colleagues and primary care in terms of making sure that the source systems that primary care are using are shared. But I believe there is potentially, and again, I'm not close enough to know the full detail of this at this stage, is that there is an element of choice or opting out and it not being mandatory across practices, depending on who their umbrella organisations are. But again, that's something I can get clarification on for this committee.
Thank you for that.
Thank you. I think what's coming out from this discussion at the moment is we have a lot of interest in terms of what digitisation is actually happening, and I think that's something we'll pick up in the work programme to bring back, because I think obviously our colleagues are more here from the county council side of things than the health side of things, but there is something that we need to be looking more into on that, so we'll certainly pick that up. I've now got Councillor Harrison, please.
Thank you, Chairman. I want to raise the organisations currently with access and the next data sources to be developed and added. NLAG is not included in them. That would be great concern to patients from East Lindsey, many of whom use Grimsby Hospital and sometimes Scunthorpe. I'm surprised if it's not going to be on the list. Could you perhaps explain that, please?
Thank you, Councillor. Yes, I believe NLAG are on the list to do. I didn't include them on the report as I don't think they are imminent in the next couple of months as of when the report was written. But I do know that STP colleagues are discussing with NLAG colleagues to be able to share that as a data source, because as you say, it is a key one, similar to our NWAFT organisations as well. So yes, NLAG is, I think, on their list to do on the roadmap. I just didn't include it on the report for immediate next steps.
Thank you, that's reassuring.
Thank you. I've got Dr. Wookie next.
Thank you, Chairman. This discussion rather implies that this is something quite new, whereas in fact, to my personal knowledge, it's been going on for nearly 20 years, one form or another, and the vision, even right back there, was to do what looks now to be almost close to fruition. So in that sense, it's very good news, but very frustrating that it's taken so long, largely due to NHS England rather than anything local. I'm just not absolutely sure. Looking at the document, it talks about things will involve to include data, but as I understand it, it is already happening. And could we just have an answer about whether there's access in both directions between secondary care and primary care, not only ULHT, but as Councillor Cleaver has very importantly said, what about other providers as well, including EMAS, as to whether there is a two-way stretch, and also whether part of the training of this includes people understanding each other's systems so that they don't spend 20 minutes trying to sort out what it actually means because it's a different system. And similarly with LCHS relating to primary care, which hopefully doesn't happen as much as it used to on a personal basis, very sadly, and therefore it's all the more important that there is excellent communication between community nursing and also health visiting and primary care. And the last thing, which I think is a bit more complicated and maybe some while down the line, but such things as child protection and the issues that arise from child protection, most of the disasters that we've all known about in the last 10, 15, 20 years are when communication breaks down between the various institutions, and that means health, social care, and the police, all of whom are quite precious about sharing their data. And I just wonder whether this is on the horizon as a feasible project or not. Thank you.
Thank you. So a couple of points there from your questions. In terms of the analytics, yes, I think there is work already started in terms of the sharing of data for analytics purposes across different organisations. I know colleagues in our intelligence teams are already talking to STP colleagues about data intelligence sharing and how that might best be reported and shared across different organisations for their different purposes. So that is started already, as you've mentioned. The secondary care and primary care element of sharing, what I've included in the report is as I knew it when the report was written just towards the end of last year. So STP colleagues, if I go back to them, will be able to advise on the latest roadmap of including source systems. But my understanding is that the overall sort of end goal is to make sure that all health systems, as Theo's mentioned, from all health departments are visible on the care portal for health professionals within their own organisations to be able to share that where they don't already have it accessed via EMIS or System 1 or other systems. But also to make sure that those third party and outside of health, including ourselves, have that access. So I think the overall sort of end goal, as we've mentioned, is to make sure that those primary care and secondary care different departments and organisations do have their information shared and can access the information that they need via the portal. And definitely, as you mentioned, around the LCHS and the nursing and the visitors, that community information is vital to be able to give that holistic picture of the person's record. Yes, as you've mentioned, in terms of training, again, I think that is the intention of the STP to make sure that as each new source system comes on board, people are fully aware of the types of information that they're being presented with and the understanding around using that data for their own sort of day-to-day workings and liaison with service users and patients. In terms of child protection, yes, that was one of the key factors really in terms of the business case when STP first started to think about the care portal in its current state, was that making sure that we are addressing one of those issues in terms of the data sharing or the miscommunication or the lack of data sharing that has happened in previous reviews of cases of that nature. Child protection information sharing was one of the first source systems included on the care portal, but I know that there are ongoing conversations about children's services data in general being involved in this. Obviously, we're coming at it from an adult care point of view, But I believe there are discussions ongoing between STP colleagues and Children's Services about making sure that the wider children's information is shared in an appropriate fashion as well, to make sure that we can try to sort of mitigate some of that. In terms of police, I don't currently know whether that's a conversation that's ongoing already or on the roadmap for STP, but again, that's something I can discuss with colleagues. I hope that answers all of the comments and questions you've made. Theo, did you want to jump in?
Yeah, just to come in very briefly on a more general point, I think the point was very well made there. It hasn't been a recent thing. Actually, data sharing of data safely across different organisations and departments within the health and care has been a long running thing. I think you mentioned 20 years. So this particular project for Lincolnshire has been some time in its fruition, in its generation, and coming to fruition now. So I think I'm right in saying, Sam, that actually the bulk of the work hasn't necessarily been on the technical side. It's been more of the agreeing what data can be shared with who, getting the governance right, understanding each other's worries and barriers to sharing that data. And there's been a huge amount of work understanding what individual staff roles would use that data for and whether it would be safely. So that as very much the work there continues across many different players. And you're right, Sam, the Children's Services, the police, primary care, who are, of course, individual organisations working, GP surgeries and primary care networks. So that work is ongoing and all builds up to the timetable that Sam mentioned there that is covered in the report. But there are other organisations coming on board with that. Just a quick one on the systems and the ability of staff to use. Now, as a social worker would look at the care portal information, they would look at it through Mosaic because that's their system that they use. So they're familiar with using Mosaic. It comes across in a format that's familiar to them, just with some additional information on there. So they don't have to navigate a different system. And this exactly the same is true for health workers, primary care workers. Wherever you are from, you are using it in your own local system context. So that your training and your ability to find things is more familiar to you. So that's been the intention of the care portal, and it's not another system. It's merely a window to look at information that is useful in your role.
Thank you.
Thank you. I've got Councillor Woodliff next, please.
Thank you, Chairman. Well, I'm really very strongly in favour of data sharing. I think it's very important, particularly regarding child protection. I think it's very, very important. But I suppose the question in my mind is how secure the system is, because although I'm very strongly in favour of it, the more people have more access to a system, the more chance there is of information being passed into the wrong hands. Because obviously information is power, and power and money tend to go hand in hand. And there are people who would probably have an interest in people's personal information, particularly health information, particularly insurance companies and so on. Others might well have an interest in that. So I think whilst I'm very strongly in favour of data sharing, I think it's particularly in terms of child protection, I think it's very, very, very important to ensure that we don't have any more of those very, very unpleasant issues we've had in recent years. Nevertheless, I am concerned about how secure the system is, what measures are in place to ensure that the system can't be hacked, what systems are in place to make sure that if somebody does use information incorrectly, they can be tracked and dealt with. That's the thing. Security is very, very important in information. So what systems are in place to make sure that the information is used correctly, that only certain people have access to it, and how it can be sure that the system itself can't be, I think that popular word is hacked. Thank you, Chairman.
Yeah.
Are you happy for me to pick that one up, Theo?
Absolutely, Sam. Yeah.
Thank you very much. Thank you, Councillor. Just to mention around the information security, the systems are in place in the same way that health and care are managed for all of their case recording systems. So we have robust governance and clinical sort of check-in groups. Like I mentioned earlier, we've got the information governance are heavily involved in terms of making sure that we are working to those criteria that we would for any system, regardless of whether it was electronic or a paper-based system. And there is an ongoing review in terms of the data set and the appropriateness of the data sets that are being shared. So we are not giving blanket access to every new organisation that comes on board that requires access to it. And as Theo mentioned, a lot of the discussions are less around the technicalities of sharing the data, but around the whys and the wherefores. So making sure that an organisation has access to all of the data it needs to run its business and to deliver to our service users and patients, but also that it's not more data than they actually require. So as an example of that for social care, the initial data set that we've agreed to share with health and for health to share with us is not the entire record at this stage. That is under constant review so that we can talk to our practitioners to make sure that they have access to the data that they need. But there was a lot, as Theo mentioned earlier, a lot of conversation with our health colleagues about what wasn't appropriate to share with social care in terms of what was on the patient record. So there isn't blanket access given. All users that are granted access have to sign up to their own local information sharing agreements and their codes of conduct as members of staff in their own organisations, which are shared across the source systems. And part of the kind of technical security on that is they all have individual logins, they don't share passwords. And that's all within that code of conduct and that information sharing agreement, that they are using the data just for the purposes that they need. They are only accessing the records that they need to access for the purpose of doing their job. They're not going into random records and looking for information that they shouldn't be going into. From a social care point of view, currently our access via the in context window in Mosaic only allows somebody to look at a service user that they already have access to on their caseload. They can't patient search across the whole care portal at this stage. That is something that's available with the direct access. So our hospital social workers that are on the pilot for the shared care planning, they have direct access to the portal, so they would have the full functionality, including patient search. But again, they are signed up to information sharing agreements in that case. And as I say, it is that login and password authentication, so people can't access the information without having that granted to them. And that's managed currently by ULHT as the hosts. So each new user, from our point of view, when we get notification of new users that need access to the system, we are running that through ULHT, and they are the ones that are managing the password management. And if people forget their passwords and things like that, that's all managed through them. In terms of an audit trail, the system itself requires users on the health side to claim a legitimate relationship with the person's record that they are wanting to access. So when they patient search for somebody, it doesn't just open up the record to them, they have to declare what relationship they have to that person. That could be as an ongoing patient and as somebody who's working with them, but there's also a break glass function which enables people in an emergency, say if somebody's working in the emergency department and needs to quickly access the record, they can do the break glass function, which is a quick view of the person's record, and it gives them a limited view. If that person then required access to that record on multiple occasions, they would then have to go back to claiming that legitimate relationship, and that's all audited trailed in the background. So your comment about if potentially somebody was accessing it maliciously, even if it was part of their role to have access, and we found that there was potential for disciplinary or there was a suggestion that somebody might be using it maliciously, then that can be trailed within the system as to which records they've been into and when. And I think I've already mentioned about information sharing agreements, so staff are signed up to those as well. I think that covers everything from my point of view, Theo.
Yeah, just quickly on what Sam's describing is the sort of correct use of the system once the system is in place. What there is for all social care, clinical systems, or health systems, there is an approvals regime that's run by the Department of Social Care. So I think what I'm thinking about is the example, the circumstance where the system's operating fine, the users are working within the structures that Sam mentioned. There's an audit regime, there's records of logons, there's backups, but how secure are those systems from, say, external attack? There is operated through a arm of the government called NHS Digital. There are a series of standards that systems need to adhere to and to meet to be approved as such by the government before they are allowed to be offered out to either NHS organisations or to local authorities in terms of social care systems. So the systems that we use, as in Mosaic through the company Serverlec, and also I think is it InterSystems who run the care portal system, and likewise with the many many clinical systems that feed into the care portal will all have been through that approval route. So there's a level of assurance around the standards that those companies and those providers are achieving in terms of security of the system, where the data is stored, that it's in a place that's secure and not in a file server somewhere in, I don't know, an unregulated environment somewhere in the world. So there are those standards in place before we even get to use those systems. And then we, through our procurement regulations and contract management with those system providers, we need to get the local assurance that sort of reiterates that. So we go through that on a yearly basis with our providers. So that should provide a bit of assurance around that. Although what I will say, we've all seen there's been health providers actually in Lincolnshire who have been effectively held to ransom through hacking or phishing emails, that type of thing. So there's constant vigilance there from systems colleagues and also information governance colleagues.
You may briefly come back, Councillor Woodliff.
Just one comment, basically. Is this monitoring real time? I mean, it's agreements and contracts and all that type of stuff is fine, but people are law abiding and such. But people who are on the offensive don't bother about those things. Is the monitoring real time? Is there a random checking of who's coming onto the system and not? Because sometimes you need those things. Because a preemptive strike isn't going to bother about agreements. They're going to go in and they'll just take what they can. That's the way warfare is on information. Anyway, thank you very much indeed, Mr. Chairman. Thank you.
Thank you. Councillor Allen, I have next.
Thank you, Chairman. I've been almost at the end of the list. I think a lot of the questions that I was thinking about might well have been dealt with now. I've got the issue with these sort of systems is they're greatly dependent on the extent of the record and the quality of the record and the accuracy of the record and the up-to-dateness of the record. If those aren't managed, the great danger, I think, is that you can get into situations that mislead you in particular directions, with whatever the ramifications are associated with that. And I from hearing the presentation, I have no doubts about the difficulties and the simply the amount of information that's out there, perhaps, to put into these systems to make them work properly. There is that. The particular question I've got is, I think a lot of our healthcare takes place outside Lincolnshire. I know from personal experience that information, and going back to it, the transfer of information must be a good thing if it's done in a correct and proper way, and it does do all the things that it's meant to do. But I know from experience that there isn't a great deal of transfer of information between hospitals in Nottingham and Lincolnshire. Never mind the issues associated with ensuring, that all the primary care records are available to the hospitals and vice versa. So the question is, well, what happens to the information that's outside the county? And the second thing is, which is perhaps even more concerning, is that although it's relevant to the question that I've just asked, is there a Nottinghamshire mosaic being developed, or is there a Cambridgeshire mosaic being developed, and is it being developed in an entirely different way from a process and the electronics part of it and the data holdings part of it, or are we developing the Lincolnshire mosaic under some guidelines that exist that ensure that there is some degree of comparability then between the various systems that are being developed, so there is a possibility that those systems can talk to one another? Because if we're having 20 or 30 of these mosaics covering England and Wales and that don't talk to one another, it seems as though we're missing a trick.
Theo, did you want to start, or?
I was just going to mention about the, I think they still call it the LICRA, the Local Health and Care Record. I think there's some standards that have been set by the government around what would constitute a local health and care record, of which our example within Lincolnshire is through the care portal that the report is featuring our involvement with. So just to give that reassurance there of it will be very similar, if not the same, across different parts of the country, because we're all working to those standards set through the Department of Health. There is an initiative called the Local Health and Care Record, the LICRA. We know people love their acronyms. That is another one. But that is effectively setting out what is the standard for the East Midlands and how systems can talk to each other, because there is that awareness of cross-border. People might live in one part of the East Midlands, but their GP might be in a different county. Certainly, when you get to specialist services, people will go outside of the county. So there is a group, and I know that the lead in the NHS on the care portal, Dave Smith, he is a lead role in that Midlands LICRA, and is also advises national colleagues on what the standards should be. So there is some of that covered. Sam, I don't know if there's any more detail that you can add.
Yes, I was just going to mention there's a very brief description of it in the report, just to kind of context set from a social care point of view, that, as Theo's mentioned there, NHS Digital do have a national requirement and governance roadmap in terms of local and regional shared healthcare records. So the intention is that there will be provision in regional and local areas to be able to share health and care records across the different source organisations and systems, recognising, as the councillors mentioned there, around the fact that there are multiple systems, that different organisations within a local authority area use different systems, and then different local authority areas, even close to each other or further apart, use completely different systems and are within their rights at this stage to be able to select those different systems that don't necessarily naturally interface with each other. So NHS Digital have set out that roadmap nationally for local and regional areas to share their healthcare records. So The intention, I think version 1 of that was to connect NHS providers and use of unstructured data by the end of September last year. We got ahead of ourselves in terms of the social care data because social care wasn't necessarily mentioned in that first stage, but we knew that it was potentially going to be on the NHSD roadmap coming up. So we got ahead of ourselves and got social care included in that local collaboration. But the intention, we assume that the next phases would include structured data and social care and care planning capabilities, not just health systems to be able to share across within their own borders. So in terms of cross-border sharing, it isn't currently possible to interface our county border organisations, local authorities and health organisations systems into ours, and there will be versions of Mosaic and other products that do the same thing as Mosaic and the same thing as health organisations case recording systems, but it is a longer piece of work to make sure that those can interface with each other. But as Lincolnshire has proved, products like the Care Portal enable that to happen quite easily once you get the source systems onboarded. So we are proving by example that we can use one platform that will enable multiple source health systems and non-health systems to effectively talk to each other and display in the same platform for practitioners and workers to be able to see. So where we've mentioned our immediate neighbours in NLAG and NWAFT, I think the intention for Lincolnshire certainly is to talk to regional partners about how we might connect with Nottinghamshire, Leicestershire, and others around our local area, regional area. So yes, it's definitely on the cards, but I think it is, as you've recognised, it is a difficult activity to finally get to. It's the holy grail that we're aiming for. Thank you.
Okay, thank you. Councillor Whittington, you'd like to come back.
Yes, thanks, Mr. Chairman. My original question, follow-up question, was based on a response to the question that Councillor Winston asked about NLAG, because my brain then eventually started to think, well, it's referred here on page 30 that North West Anglia are part of the process. So obviously we've got a lot of our residents in Stanford, the Deepings area, that sort of go to Peterborough, Stanford Hospital, you know. And then because I also sort of comment that Dr. Wookie made, because I was working in the health service, I can remember as Dr. Wookie said, 20 years ago, there was something to talk about, you know, unified NHS medical records, and I think it got, the costs kept escalating, and eventually it was just deemed to be too expensive and too hard to do. And even 30 years ago, in the early 1990s, the NHS were working around standardised data sets. So this has been a long time coming. So my question was going to be about how all the different systems, you know, ex Lincolnshire would working together. And I think that's been answered. And of course, it's not just within NHS East Midlands, because potentially we'll have residents in the Gainsborough area who look towards Doncaster and Sheffield as their main providers, which is in Yorkshire. Residents down right down in the deep southeast of Lincolnshire who tend to go to King's Lynn, which is in Norfolk, so which is NHS East. So it's a question of how all these work. But one thing potentially, and this is again, I'm currently awaiting a back operation, which is going to be done not within the NHS because the waiting lists are so high, but by a private spine hospital in Peterborough. So potentially, the NHS quite often uses the private sector to deal with some of its waiting lists. Now, potentially for mine case, I suppose in 20 years' time, I need social care because I've got mobility issues. And the fact that I've had a back operation potentially is not there because it was done by a private hospital. So again, I'm starting to think about potentially that, you know, covering everything off, you know. Now, presumably, the records of my back operation would be contained within my GP records. But potentially there may be lots of stuff, you know, where the NHS uses the private sector and other sectors. You know, how would those make it into the system? And obviously, a lot of NHS services are provided on a regional basis. You know, we have specialist burns units, specialist cancer units. Some services are even provided on a national basis. For instance, children. I mean, if a lot of children who have really, really complex needs would go potentially from Lincolnshire to Great Ormond Street Hospital in London. So again, it's how all of this is picked up. Because obviously the Holy Grail was mentioned, I think, as being a standardised national system. But the NHS tried that many years ago and gave it up because it was going to be too expensive and too complicated. So thanks, Mr. Chairman.
Thank you, Councillor. Theo, did you want to jump in on that one, or?
I do, unless you've got an answer to that. I think in terms of private healthcare, I think healthcare records of where referrals are made, who's undertaking procedures, and the results of those are stored locally. So those would be on local health providers' records. But yes, I think the sequencing of bringing on board data sets from different organisations and the timetable for that's probably the answer to a lot of these questions, and where the progress has been made. Certainly it has been quite rapid over the past year or so from quite a slow burn build up, but where we've got to is that we've got the local providers of healthcare and the local providers of and commissioners of social care integrated into this, and now the project as a whole, which is run by the NHS, we are part of that as social care colleagues and representatives from the county council. But there is a timeline to start to look at elsewhere to pick up more records to make that complete, and as that timetable goes on and is implemented, it will become fuller and fuller to get towards that holy grail of a complete record with appropriate access, which is important, and we've touched upon that, to the right people in the health and care system. So I think that timetable and that, which has been indicated in the report, but the detail of what's next and when other services can come on board, that's something that we can go back to the lead on the care portal in Lincolnshire just to get hold of.
Thanks, Theo. I was just going to add to that, just to mention in terms of, yes, we've worked from the middle out, as probably most local authorities and CCGs have, in terms of sharing within the local authority our health and care records and those that we feel need to be shared to make that better experience for our service users, patients and our practitioners. And then obviously as has been recognised and acknowledged by councillors in this meeting, it's a difficult thing to then move outwards to the wider systems across our neighbours and our across the rest of the country. So it's definitely on the cards, and as has been mentioned, it's been years and years in the making, and I think NHSD and social care organisations understand that we will never get to a point where it's one system for all, because that wouldn't be practical across health and care. But I think the end goal that has been mentioned around a standardised data set is something that NHS Digital are definitely looking into, in trying to make sure that if systems are trying to share data across within health itself and across health into social care and vice versa, that actually we move to a point where there is less confusion and misunderstanding around terminology and jargon and language used. There is less difference in the way that things are recorded, how coding is done in the back end of systems, that actually we do get to a point where it is quite more easy to share that data in a fashion that would mean the same thing or similar to both health and care professionals that are coming at it from different angles. So NHS Digital are definitely looking into frameworks that would enable different systems to interface their data with a standardised data set, but it wouldn't necessarily, we wouldn't be looking to have one system for everybody. It would be multiple systems having products like the care portal to be able to share that data through. So that's where we see the picture moving to. And definitely, once we've got past the hurdles of sharing the multiple source systems within our own locality, is then looking at our neighbours. And as Theo mentioned there, in response to the comment around private records, again, that's a completely different arm of the pathway as well, and different healthcare providers that might not necessarily be connected into our statutory providers as well. So yes, it's moving further and further out, and is, as our regional colleagues are doing the same thing in their own localities, because they are also having to adhere to these NHS Digital governance requirements, then hopefully we'll all meet in the middle on those as well. So hopefully that answers the questions.
Okay, thank you. Councillor Allen for a very short one, because I'm incredibly conscious of the time.
It is a very short one. Chairman, can we have a return in 6 months or something like that? So that it's such an important issue, and it's been so difficult in the past to actually resolve, and any degree of success I think would be reassuring to us. So could they return perhaps in 6 months and say what further lessons they've learned and how they're resolving some of the issues that's been raised today? I'm looking at particularly at Appendix B, and Appendix B in my view needs to show a different picture, should we say, in 6 months' time, because at the moment it seems to be showing that it's less popular as time goes on, and I would like to see that altered so it becomes more popular as time goes on.
Yes, thank you, Councillor. That's actually in my proposal. I was going to suggest they come back in 6 months' time. So I'll make that proposal now. I propose that we have an update in 6 months' time, probably to coincide with the digitisation of records from our NHS colleagues as well, and try and get a piece together there. And we update, we note the update, and that's it. That's my proposal. Thank you. Seconded, please. Thank you. Seconded. All those in favour, please show. Thank you. That's supported. And I'd just like to thank our presenters. Thank you for your time.
Thank you very much.
Thank you, Chairman.
Thank you. I'll now move on to agenda item 7, the Lincolnshire Acute Services Review, finalisation of the committee's response. You'll find this on pages 35 to 40 of the report pack, and a draft response was circulated on email on the 18th of January based on the views of the working group, which had met on the 6th of Jan. I'll hand over to Simon, please.
Thank you, Chairman. As the Chairman has said, this the draft response, which was circulated on email and is also a paper copy is in front of you this morning, was prepared following a meeting of the working group earlier this month. The response is in, I suppose, 3 parts: a brief introduction. Then there is a section which follows the survey questions that members of the public and other organisations had been asked to complete. And the final section picks up several themes that have emerged during the consultation. And there is also, on page 11, some comments on the consultation arrangements. Just to make it clear that the committee has taken advantage of an offer from Lincolnshire CCG to submit its response by the end of this month, but the public consultation closed on the 23rd of December. So I'll pass over, Chairman, to members of the committee for their comments. Thank you, Chairman.
Thank you, Simon. Yeah, and I just would like to reiterate our thanks to our NHS colleagues for allowing us that additional time. I think we found it incredibly useful. I've got Councillor Wotton first, please.
Yes, thank you very much indeed, Mr. Chairman. I welcome the committee's comments on this draft report, in particular on page 4, they strongly disagree with the A&E arrangements at Grantham. Today marks 1,982 days since the temporary closure of Grantham Hospital A&E overnight. Now, when we were told it was closing, we were told it was temporary for 3 months only. 3 months. We're now nearly 5.5 years down that road, where myself, Councillor Linda Wootton, Councillor Mark Whittington, Councillor Rosemary Cabley-Brown, and also Councillor Charmaine Morgan and Jodie Clark from Fighting for Grantham Hospital have campaigned along with residents of Grantham to keep Grantham Hospital open as an A&E, not as a UTC+. Now, the issue at the time was that the hospital at ULHT said there was not enough staff, middle grade doctors. They recruited enough middle grade doctors, and then along came the clinical senate, which said it was too dangerous to keep this hospital open. So now we've gone down the route of a consultation whereby minimal people attended this consultation. The last consultation we were at, only 15 people turned up, and myself and Linda were 2 of those 15 people. So I don't think there's been enough consultation throughout Lincolnshire. Certainly we were promised, as Councillor Mark Whittington made a motion at Council to say that every household in Lincolnshire should be consulted, and we don't believe it has been. So therefore, you know, we will still continue to fight for the hospital to be retained as a 24/7 A&E. One important point I'd like to bring to your attention: children in Lincolnshire, Grantham has the second largest population of children, more than Lincoln, and but we've got no emergency paediatric treatment at all in Grantham, and patients, children have to travel to Lincoln elsewhere for treatment, as do many of our population who have to endure bus fares, taxis out of hours, high costs to get treatment, which could have been and still can be held in Grantham. So although I could talk for ages on this, Mr. Chairman, I should just say thank you for your comments. Thank you for those on the working group who supported our cause, and hopefully the whole of the committee will endorse the report. Thank you, Chairman.
Thank you, Councillor Wootton. I've got Councillor Whittington next.
Yeah, thanks, Mr. Chairman. And thanks, Simon, for the report. And thanks to Councillor Ray Wootton for putting the views of himself, Councillor Linda Wootton, myself, and Councillor Rosemary Cabley-Brown, Councillor Morgan and Jodie Clark. I mean, you know, we have been, as Councillor Wootton said, been campaigning on this now for quite a large number of years. So I wholeheartedly endorse Councillor Wootton's comments. My question is, the report, I mean, I've read the report through, and it is a very, very good reflection of the discussion that we had and all the issues and concerns that we raised. When I was then looking at it in overall, the very first question on the need for change, on page 2, we've ticked the box strongly agree. We strongly agree there's a need for change because the benefits would improve quality of care, reduce waiting times, better outcome for patients, whatever, the 5 points listed at the top of page 2. And then when we've actually gone and looked at the individual parts, we've gone orthopaedic surgery, tend to disagree. Grantham Hospital A&E strongly disagree. Acute medical beds at Grantham Hospital tend to agree. Stroke services tend to disagree. So when we've looked at the 4 component parts, the best we've got is a tend to agree, and the rest are all either tend to disagree or strongly disagree. And on the case for change, we did strongly agree. It just looks a bit incongruous to me. When I looked at it, I thought, because I know we had the discussion, and I know why we said strongly agree for the case for change, because I think we believe there's a case for change. So I think it's really important to sort of make the observation that, yes, whilst we agree, strongly agree, of the need for change, we don't actually think any of what's being proposed really goes anywhere towards addressing that. So I just think that point, you know, because if you look here, somebody might just look at the first one and go, oh, they strongly agree. But actually, when we look at the component parts of what's being proposed, we're less warm on it. Does that make sense? Thanks, Mr. Chairman.
Yeah, thank you, Councillor Whittington. I don't think I could agree any further with you. I think we all, as you say, agree that we feel there is that need for change. The problem we have with that first question is it is a tick box exercise, and unlike the others, there isn't that space to add in. And I think that that is something you're absolutely right. Whether or not we add that, perhaps. Yep, Simon, I'll bring you in because you think there's an area where we can.
Well, certainly we could put another section in Part C, right at the beginning of Part C, case for change, and just record the comments that Councillor Whittington has stated.
I think the great difficulty is with that if you were to look at it from the first page, it doesn't open that up, and that is one of the problems, and I can fully understand where that is. Unfortunately, I don't think we can do it in any other way. It's a shame you can't perhaps even have something at the side of it say, please see note B later on or whatever, that might direct them further away from it, because, yeah, it would look confusing that we agree, but at the same time, then we don't disagree with anything almost. So I can fully grasp that point, and I think that is something we will have to try and bottom out.
I mean, we could do this because this is on a Word document which we have control of. So it's not a form. The form was copied in, and then we followed the format. So in fact, we could, if you wanted, put the free text directly underneath that and create another box. I mean, there's no. So we could put that there if that's helpful, rather than in section C. So it is directly.
I think that would be much more worthwhile, because I think it'll show a little bit more understanding as to why it's been done in that manner. I do have quite a list of speakers now, so I've got Councillor Smith next, please.
Thank you, Chairman. To my point, I agree wholeheartedly where we've disagreed in terms of Grantham and other areas, because it seems to me at the outset that what is being proposed is that City of Lincoln Hospital and Boston Pilgrim Hospital are increasing in service, yet Grantham, Louth, although isn't mentioned, I suspect that will come later on potentially, are losing services, which, as has been alluded to, for people that are in my division, is next to useless, as in Grantham, because it's a long journey, and what will actually happen is the majority will either go to Nottingham, as I do myself, so there is a personal interest in this. In terms of orthopaedic care, I go to Nottingham for my orthopaedics, so there is a personal interest. But my actual question is in relation to what the report says: integration between social care, social and medical community beds and medical beds. And it doesn't, and it didn't, and none of the medical individuals we had actually alluded to how this will work, and what constitutes community care. Because the integration previously for community care or adult social care and medical care have, to be blunt, not worked out as promised. And usually it's LCC that's been left with holding the proverbial baby, and we've got to fund it. And actually, if you look at our finances compared to the National Health Service, we're actually quite, and even as a government department at Westminster, the local government is cash poor in comparison. So that, I think we need to say explicitly, must be avoided. We mustn't be left, again, holding the baby. And going on from that, as I said in my sort of notes, what constitutes a community bed, because no specifics were given. Would it, for example, be used for non-medical detox of alcoholics? Because there is no facility within Lincolnshire to do that. There is facility for medical detox, but for medical reasons. But if an alcoholic needs to detox, and it is not for a medical emergency, there are no facilities. So would they be used for that? Which, of course, would actually take most of them up, because that would be the only area where that facility is available, which then means other issues that would otherwise be used for those beds couldn't be. So I think we need to, as a committee, need to actually say, okay, this is your opinion or appraisal, but what does a community bed constitute? What is it used for? Because it doesn't say that, and we weren't given any information about that. while we had the presentation either, there wasn't anything stated what a community bed will be used for and constitute. And I think without that, it's very difficult for us to answer that question, because I think that may materially change our answer. But on the whole, with the exception to that area, I agree wholeheartedly with what the working group's done. Thank you, Chair.
Thank you, Councillor Smith. Dr. Wookey next, please.
Thank you, Chairman. I think what I want to do is just to concentrate on where you are and where Health Watch is in relation to this, because I think it's very important, if possible, that we cooperate as we have done increasingly well recently. First, I'd like to say that I really think that the layout of the report is really, really good. We've had so many things, not only here, elsewhere, which is quite difficult to follow what is actually being said. This is very clear. You can see immediately what it is, and so I don't know who was the author, but I think it's great and be perhaps an example for all of us as to how to produce a clear report. As far as our position at the moment is that we are obviously concerned with the responses that the public are producing, and we're still collating those. But before that, we sent to the CCG a list of conditions which they should follow in order to have a full consultation, particularly seeking out reassurance that they included hard-to-reach groups and others throughout Lincolnshire. And the other thing about that, which perhaps wasn't discussed directly, was that the consultation was going on in the middle of COVID. And I think that is something that probably accounts for the fact that some of the attendances were very poor, and it requires a lot of commitment on people's part to go into a meeting, if it was a live meeting, when there was a considerable amount of COVID on. So I'm just not sure how wide the consultation could be said to have been successful or not. I think as far as the documents are concerned, we have not sent a full report yet, but we are in liaison with the CCG that it is our intention to follow up what we have sent them with a more detailed report. And if we may, we'll take on board what Health Scrutiny have said with this very clear document, because I think that's really helpful. As far as the actual, I don't want to go into detail about the things we've already discussed, both when I've been here and when Maria was here in my place. But I think a lot of the things that you've emphasised and perhaps has influenced your conclusions are things that we have raised ourselves, or we've raised actually at this committee, and other things, particularly things like transport and other issues, and that constantly occurs right the way through. So I think what we need to do is to keep in touch really with how we're progressing, and I'm still not clear, and I'm not sure our officers are quite clear as to how, and we know that there's a deadline of the 31st of March, but just how much interactions there may be between now and then, while the CCG does its work and tries to sort out the returns that they've had. So I hope that's helpful, but we're very keen. You know, I think we both have the same objectives, and we also have the same problem of trying to clarify local issues from county-wide issues, and issues which are important to the west of the county, which might be the contrary to those in the east. So it becomes quite a tricky issue for such a large county. So I hope that helps anyway in moving forward.
Yes, it does. Thank you, Dr. Wookey. I think we'd certainly welcome that sort of correspondence working between ourselves, and it has been a good working relationship between this committee and Health Watch Link, so I think we fully appreciate that. So we'll take that on board. Thank you. I've got Councillor Bilton next, please.
Thank you, Chair. It was just to agree with Councillor Whittington, and my suggestion would be that that response was changed to neither agree or disagree, which gives a middle position. You know, you don't have to actually respond to that first question.
Yeah, thank you. I think it's something we can consider, but it would have to take for the committee to decide upon that. I still am very much of the view that this was actually, throughout the working group, incredibly finely balanced. And actually, some members would have gone into different tick boxes, which is kind of how we came to the agreement of where we were. And I think providing, in my mind anyway, that we do give some reasoning behind why it is that we say that we agree with the case to change, but not necessarily what's being outlaid, is, I think, quite reasonable to how it was discussed within the meeting. I'm sure other members of that working group would agree that it was quite tricky to try and work from different areas of the county that you did come through, and that's why it's there. So I would personally be more keen on trying to add to why we chose that, but I can see where you're coming from, but it is down to the committee's choice, and I would welcome any feedback on that. Got Dr. Thompson next. And then we'll come back to it, obviously, at the end and make our final decisions at that point.
Thank you, Chairman. It's to follow up on that point. I wonder whether the explanation could go in the introduction so that it's in front of the answers and clarifies the disparity. It would then be read before the responses. Thank you.
Thank you, Dr. Thompson. I've got Councillor Parkin.
I think we're in danger of really overthinking this, and I do apologise for not having been at the working group, but I'd got a committee clash that day. I'd also got COVID as well, so was all over the place. For me, it's just really, really straightforward and clear. Yes, we agree that we've got the case for change is made. I don't think any of us would dispute that. And then there's a list of individual proposals, and we've clearly addressed those in detail in the responses, and I actually think it was really clear. So I think I don't know, no disrespect to Mark, but I don't think there's an ambiguity at all. As I would say to my children, let's not overthink this.
Thank you, Councillor Parkin. Though I would tend to agree with you, I don't think there would be any harm in perhaps just adding a little bit of a sentence, because from the public's point of view, they weren't there in the meeting. They may not understand in the same manner of where or how we came to our conclusions, and actually how finely balanced it could have been along that process. So that would be my view. I've got Councillor Linda Wootton.
Thank you, Chairman. I'd just like to thank the working group that worked on these 4 subjects. And also I'd like to thank this committee with our chairman and the previous chairman of every time that, as a member of the Grantham councillors, I've and my colleagues have had to come to this committee, and we've gone on and on about the problems with trying to save our A&E hospital in Grantham Hospital. You've always shown us consideration and compassion, and I know it probably is not so important to all of you, but it's been very important to all of us, and I really do sincerely thank you on behalf of the public that we represent as well. Also, when's a consultation? Not a consultation. From the beginning, the activists have thought that we've not been listened to, and we've been along to every meeting, and we're always saying the same thing. And we come up with under 3,000 people have gone online to do the consultation. But as Dr. Wookey said, I'm sure there's some more responses to come in. And at the end of the day, we've done the best we can. You've all helped us, but what will be, will be. Thank you, Chairman.
Thank you, Councillor Wootton. I haven't got anyone further to speak, so we'll go back to... Oh, Councillor Woodliff has now come in.
It's a very short statement, Chairman. I'd say that if we're not happy with the status quo, and I'm not, then the case for change, well, I strongly agree. Has to be that way, doesn't it? And I'm not happy with the status quo, so therefore I'm strongly in favour of change. And I think the committee was correct. Thank you.
Thank you, Councillor Woodley. Councillor Cleaver.
Very quickly, yes, I do agree with Councillor Whittington. I think that it is inconsistent to say strongly agree at the top of the thing, and then that isn't mirrored with the answers on the other questions. And that's not our problem. I mean, the problem with that is that there isn't a clear question that first need for change paragraph is referring to. Are we strongly agreeing that the consultation is focused because we believe that significant and permanent improvement is required to them? Yes, we do. Do we agree that the benefits of changing will include the 5 bullet points? No, we don't. So could I suggest that we don't fill in the box and explain our position on those 2 points that are in the paragraph as a possibility? And could I also formally propose a vote of thanks to those that served on the working group, please? Thank you.
Thank you, that's much appreciated. I think, as has been alluded to, we're making hard work of this now. I think the simplest way forward, and I will make this as a proposition, I take on forward your vote of thanks as well. And I was going to say the same, especially to Simon, who of course is the author of this and has taken our comments and written them out incredibly well and presented what I think is a fantastic response, I have to say. But I think that the easiest way would be to still leave it as it is, but make sure that we have an introduction and a box underneath being very, very clear on exactly what it means. And I will put that forward as a proposal, and I'm happy for anyone if they wish to. Thank you. Seconded by Councillor Wootton. I think if we're clear in that manner, we can say we know there is the need for change. We don't disagree with that. But these are the reasons why we can't support what's going forwards as it stands. And I think that that's the simplest way. Been proposed by myself and seconded by Councillor Wootton. All those in favour, please show. Thank you. That's supported unanimously, and I think that's important that we do note that down. And again, I would like to massively thank all of those and the committee for the hard work that has gone into this over not only the last 12 months, but over a number of years with some many, many false starts. And it's good to see that this is finally coming forwards, though I think we need to keep in that constant liaison with our NHS colleagues. We do want to see alterations. We're not satisfied. And I think that they've got room to build and improve on this, but they are certainly not, to my mind, or this committee's there. So, thank you. Is there anything further anyone wishes to add? No. Okay. Well, in which case, I think we'll take a vote in favour of the paper as it stands with those alterations. I'm happy to propose. Simon? Yep. I'm happy to propose that. Have I got a seconder? Okay, Councillor Wootton. Okay. All those in favour, please show. Thank you. Again, that's unanimously supported. And once again, thank you everyone on that. We'll now move on to agenda item 8, the Director of Public Health's annual report, found at pages 41 to 78 of the report pack. The report has been considered by 2 other County Council scrutiny committees in the last week, which are the Adults and Community Wellbeing and Children and Young People. One member of this committee, Councillor Stephen Woodliff, has identified a minor error which will be corrected in the online version. It's on page 3, page 48 of the agenda pack, and all the numbers in figure 1 are correct. So in paragraph 1.1, it should read, the City of Lincoln contains proportionately more than 0 to 19-year-olds than any other district. I'd now like to welcome our presenter on Teams, Professor Derek Ward, Director of Public Health for Lincolnshire County Council. And I'll hand over to you to present it. Thank you.
Thank you, Councillor Macy. Good afternoon, everybody, and apologies for that error that's been picked up. As ever, the report's been proofread multiple times, but that one slipped through, so apologies about that. I'm conscious you've had some very substantive conversations already, so I'll pick out the key points from the DPH report, if I may, and then happy to answer questions and have a bit of a conversation. The first thing today to say, just from a process perspective, is the Director of Public Health Annual Report is a statutory responsibility that Directors of Public Health in upper tier authorities must write one, must produce one, and there's a statutory responsibility on upper-tier authorities to publish it. But as you'll remember, I've always been keen to make sure that Scrutiny and other committees have had a chance to have a look at it and have a conversation about it. I think the other thing to say by way of introduction is that because this year we chose to look at children and young people and the health and well-being of that group, this is really a joint report. Well, it is a joint report between myself and Heather Sand as the Exec Director of Children's Services. So the report presents the public health perspective, but also talks a lot about what we do and what we have done to tackle the challenges for children and young people and their families, including how we've changed our service provision through Heather's directorate throughout the pandemic to make sure that we're providing the best care that we can. The way the report is structured is in the covering paper, so I think it's on page 42 of your papers. So we've got a series of chapters. Each chapter was written through public health and had lots of input from children's services managers and assistant directors, and my thanks go out to everybody who's fed in. The key headlines really are, and this may sound self-evident, but I'm sure for this scrutiny as well, you will recognise this. It's really important at a system level, including for our NHS partners, that we recognise that children are not simply little adults. We need to ensure that the services that we commission, we deliver, are specifically built and delivered for their needs. Clearly, recovering from COVID is going to be a key priority for children and young people. We'll come on to that a little bit later. And the way that we can help children and young people meet the challenges in Lincolnshire over the coming 2-3 years are really focused in 3 core areas. One is by delivering services, as I've said, made for children and young people, not cut down versions of adult services. Secondly, we must remember the basics with children and young people. Physical activity, diet, nutrition, and mental and emotional well-being are absolutely key. And if we get that right in childhood years, that will provide us with a really fit and healthy population in Lincolnshire for decades to come. I know, again, it's a self-evident truth, but it's something that we sometimes forget. And thirdly, we absolutely must have a focus on tackling inequalities in education and opportunity. That's fundamental to tackling inequalities in health. So to go into the main report, and I'll pick out a few little bits, and I'll refer to the pages when I do. And the first thing I'd say is on page 3 of the report, or page 48 of your pack. We talk often within this scrutiny and across the system that Lincolnshire has an older population, and it does. But more than one in five individuals in our population is 0 to 19, so it's a child or a young person. And sometimes we forget that. I think we lose that in our focus, understandable focus on our older adults. And that map, as we've just talked about, demonstrates the different percentages. Clearly, East Lindsey's got a low level of, or a lower level of children and young people. But as we've said, Lincoln is up in the nearly 24%, nearly one in four people are in that age band. So that differential needs to be recognised across such a large rural county as our own. Second thing I'll pick out is on page 51 of your pack, or page 6 of the DPH report. Scrutiny will remember that the very first Director of Public Health report that I did, I used the Global Burden of Disease methodology, which is years of life lost, years lived with disability, and disability adjusted life years overall, to describe the population illness across Lincolnshire. And what that does is it brings out and makes clear some mental health issues, musculoskeletal issues, that if you just look at what people go into hospital from or what people die from, then you miss. And what we've done is we've used the same methodology to look at children and young people. And the little diagram at the bottom, or the little picture at the bottom of page 6 on the report, or page 51 in your pack, shows a couple of things. Firstly, When you look at what our children in 0 to 5 sadly lose their life from, they are areas I think would recognise. So that's being born prematurely, having birth defects or brain injury at birth. But when you look at the conditions that our 0 to 5-year-olds are living with and are causing distress and discomfort and disability, there are things like eczema, infections and asthma. Again, fairly understandable given the age band. When we jump up to our 15 to 19-year-olds, the pattern changes fundamentally. So in terms of what sadly our 15 to 19-year-olds lose their life to, it's road injuries, it's self-harm, which obviously feeds into our mental health focus later on, and it's cancers. And then in terms of years lived with disability, it's migraine, but it's depression and anxiety and back pain. So it comes back to that point that we talked about a couple of years ago, that mental ill health and musculoskeletal problems start relatively early in somebody's life, as we show there, 15 to 19-year-olds, and often people will live with those conditions right the way through their life course. So that was one thing I wanted to pick out on that page. The other is that whilst we should recognise children and young people need their own services, within children and young people age bands, there are different issues and different challenges. And again, that nuance and that variation we need to reflect in our services, whether they're council services or whether they're NHS or wider services, because of the sort of difference that little diagram demonstrates. On to the next page, I'll just touch on this because it was something that was picked up by Elder Care and Community Wellbeing Scrutiny. There's a map on the bottom of page 7 or page 52 that shows the areas in Lincolnshire that the water is fluoridated in. And what it shows really is on the left-hand side of the map, down our western side, that's the area that is fluoridated. Some areas of high deprivation, certainly around Lincoln and elsewhere. But then the area that isn't fluoridated, which is our east coast predominantly, right the way down to Boston and the bottom of the county, is actually a bigger area that's covered by more areas of deprivation. So what we've got is fluoridation is absolutely fantastic at reducing decayed, missing and filled teeth in children and young people. It really works extremely well, and we've got all the data that shows that. In Lincolnshire, the area that's fluoridated is actually predominantly the more affluent area, and the area that isn't fluoridated is the area that's more deprived, and that's reflected in our data, and it's something that Adult Care Community Wellbeing Scrutiny were very interested in and have asked for a further paper, so we will be briefing now. As I said, I'll whistle through this, so I'll jump along to page 10 in the report, page 55 in your pack, and just show there that figure 9 shows the impact of COVID in terms of education throughout the timeline and where the weekly rates were. Now, because of the publication timelines for this, we had to stop in, I think it's August last year. Clearly, with Omicron, we're now in a phase where we're seeing lots and lots of infections in primary school age children. Indeed, our primary school age children, COVID rates are the highest of any rate in Lincolnshire at the moment. We expected that, to be honest, because that's the one age group that haven't had access universally to COVID vaccinations. So we are seeing very, very high rates there. But it does show that the impact directly of COVID on the number of children who are off sick is clear, but also the secondary impact in terms of teachers being off sick and therefore classes not being able to receive education. Obviously the lockdowns and school closures and children being educated at home will all have an impact that we talk about later on. On page 1257 of your pack, we talk about early years, and all I'll say here is that in Lincolnshire we have what may well be a unique model where our early years provision, our 0 to 19 provision that is funded through the public health grant, is actually delivered through the council, through children's services, with our own health visitors and our 0 to 19 integrated offer. And I think that's it's an unusual model, but a model that works really well for Lincolnshire, especially when we tie that into the fact that we also fund our children's centres through the public health grant. And though having the physical space and the staff that is Lincolnshire County Council employed and funded to deliver and support our children and young people, I think is a really good model, and has meant that we've been able to adapt very quickly to deal with the challenges of lockdowns and COVID-19. I'll rattle through a little bit further on, if I may, Chair, and I will go to page 21 in the report, 66 in your pack, and just pick out one of the points that I said at the introduction. Mental health and emotional well-being is absolutely fundamental to children and young people. It is to us all, but particularly to children and young people. And the impact of COVID, I think, can be shown on the bar chart at the bottom of that page. Before COVID, or just as we were starting to come into it, 1920, you'll see the number of referrals we were seeing across Lincolnshire for behavioural problems, sleep difficulties, etc. And then in 2021, you'll see every one of those has gone up, and some of them have gone up very significantly. Speech and language, for example, is all to do with developmental theories for children. And a chunk of that will be down to the impact, the indirect impact, as well as the direct impact of COVID. And we wanted to pick that out in the report, Heather and I. So on to the conclusion on page 24 of the report, 69 in your pack. We have described there a summary of the impact of COVID on our children, young people and their families. They've endured separation from families and friends, altered access to health and dental care, which of course is really important to this scrutiny. We've seen young people are less likely to be physically active, which increases the risk of becoming overweight, and we talked about that earlier on in the report. And we also have seen potentially an increase in harmful behaviours, whether it's smoking in pregnancy, which results in lower birth weight and other complications, or whether there are other risky behaviours. These are all areas we will need to deal with as we recover from COVID, hopefully, as we come into the spring and start to come out of the pandemic. I think we've put there, perhaps most significantly, the pandemic has taken its toll on the mental health of the nation, and the impact on children and young people is very, very large. We can, to a large extent, offset some of this because of the support and the learning that we will build into our services over the coming months and years, that we can deliver through Lincolnshire County Council, and also through the development of the new health and social care system, the integrated care systems. And we describe what we've done and what we plan to do in the rest of that page. And we come on to, on the following page, page 25, those three key areas that we've said in the report. We've got to ensure that services are designed for children and young people, not adapted adult services. We've got to remember the basics, the primary prevention, physical activity, diet, nutrition, making sure our children and young people have strong emotional and mental well-being support. And we have to prioritise our education, increasing our opportunity and access to high quality education, as that's the way we're going to tackle both health and social disparities. And there are our priorities there. I shall pause there, Chair, if that's okay. Happy to answer questions, and then maybe very quickly just cover the second paper, which is an update on the recommendations from previous DPH reports.
Thank you, Professor Ward. Yeah, I've got a number of speakers listed. It's more than likely, normally when this happens, it will probably verge into the second paper, but we'll take them and see how we progress. Start with Councillor Parkin, please.
Thanks, Chairman. Derek, thanks ever so much for that report. It's really interesting stuff. I like the emphasis that children are not mini adults, but obviously we all know that these children become adults. And you're right to emphasise the importance of those early habits, really feeding that healthy or unhealthy adult life. I think where I'd like to really passionately contribute to this is in terms of mental health. there is no doubt that our children's and our young people's mental health service in Lincolnshire is good. But I know all too well that you pass that threshold and you are falling through the gaps, no end. And I just make an absolute plea to us, Carl, please, that yes, we recognise all of the good that is being done for children and young people, but that urgently we have a look again at adult mental health services. I'm more than happy to have a conversation with you privately, Carl, about my experience, our experience with that, but it is not good, and I'd be interested in Derek's views as to what, I know that we are looking at children here, but this is an acute mental health crisis, I believe, in our adult population, and he's the Director of Public Health, so I'd be really interested in his views on that, because it's hard to, we haven't got that information in his report, so I'm really interested while we've got him to talk about that. Derek, in terms of the report itself, I think it's really good, but I do think we have missed an absolute fundamental key bastion of public health in Lincolnshire that we see, and that is what happens within our communities. You know, in many of our communities, we have absolutely thriving community sports clubs, activity clubs, and they carry a lot of the load for us in terms of provision for those young people. And I just think it's a real shame that that isn't acknowledged, both in terms of recognising the work that those volunteers do, but also recognise where and how strategically we can work with them and they with us. So I'd like Derek's comments on that. I know that, you know, all of these services that the County Council and Health are providing are key. They really, really are key. But for me, where I see our young people thrive, it's in that community provision. And I think we would be fools to ourselves to ignore that, to not recognise the benefits that that brings in terms of public health to our young people, and then not to be really doing some serious mapping about where there might be gaps and whether or not there's areas that we need to prioritise for intervention in that respect. There are those two key points for me: adult mental health, and then how we work with that community provision to both increase access but also celebrate the achievements of it so far and work more in partnership with them.
Thanks, Councillor Parky. I think the first thing to say is I couldn't agree more. Both Heather and I could have written 4 or 5 chapters, volumes for this year's annual report, and we would have covered absolutely our communities. We would have gone into more depth with mental health service provision, obviously for children and young people, but I'll come on to that in a minute in terms of adults. We had this conversation at Adult Care, Community Wellbeing and Scrutiny. Some members of Scrutiny thought there was too much in the report, others thought there wasn't enough in, and some thought it was just right, the Goldilocks paradox, I guess. I agree that this is always, as a DPH report, it's just to try to pick out particular points of being in the pandemic. We clearly focused on the impact of the pandemic as well. In terms of our engagement with communities, our engagement with voluntary organisations, we have our Connect to Support platform. One of my responsibilities is around carers and making sure we've got carer support. We have a joint strategic asset assessment that rather than talk about the deficits that we do in the joint strategic needs assessment, we've done something that maps out not just the physical assets, but the people assets we've got in our communities that help our communities. And of course, in children and young people, a lot of this is built around our schools. So we could have done a whole report just on school-based support. So yeah, I completely agree. Would have really been pleased to put more in, but it's one of those just trying to cover it. In terms of mental health, I think Sarah Connery, as the Chief Executive of Mental Health Trust, would be really pleased to have this conversation. I agree with a lot of what you're saying. We've got to look again. The report that I did a couple of years ago that talked about the global burden of disease has been presented several times to all the chief execs in the NHS. because what it shows is the impact of mental ill health on the population is not recognised in the normal way that the NHS nationally looks at things, because they look at cancers, they look at cardiovascular disease, because that's what kills people, and that's understandable. But mental health is often a Cinderella service, or services for people who are suffering from mental ill health, and particularly crisis situations, are often underfunded. And that conversation is being built into the development of the integrated care system, and I'm sure would be a very fruitful conversation for health scrutiny as well. So I'd be very happy to come along with Sarah and probably John and others from the NHS side and have that debate.
Yeah, thank you, Professor Moore. I think that'll be very useful, and
Yeah,
I
I
will
was
bring
gonna say, can I
Sarah
just
to come
propose
back
that we
in.
do
Yeah.
that in the-
I know. I think we'll add it on. It's not a problem. I don't think it needs that proposition. So thank you for that, Councillor Parkin. We've got Councillor White next, please.
Thank you. I'd just like to make some comment about the statements, the educational measures that have been stated on page 60. These percentages don't really reflect the individual variations in school performance. We have got some very high achieving grammar schools and some academies. But if I talk about Gainsborough, one of the areas that I know quite well, if the children don't get into the grammar school, the school there has been struggling for years to raise standards. People who can afford to transport their children out of Gainsborough do so to other schools in Newark or Curtin, Retford, etc. Another example is Stanford. Stanford has no grammar school. Those people who can hope that their children will pass to one of the neighbouring grammar schools. There again, the school there has been struggling, that's left the comprehensive schools to try and raise standards. So I think that children, especially children in deprived areas, are not often getting opportunities of high educational experience, and I include the East Coast as well. I know people who've said in Boston, if my child doesn't get into the grammar school, I don't know where I'm going to send them. So if people want a better measure of educational performance in Lincolnshire, they should look up GovUK Lincolnshire schools, because again, the information about primary schools, quite often, the progress scores are not encouraging in some of the schools, and I know that the Diocese of Lincoln has set up a trust to try and improve standards. The other thing I would like to say is that health visitors, I think there's a lot of people whose babies were born in 2020 who have not received a visit from health visitors. They've had telephone calls, I think. And finally, I was interested in child weight, which is on page 53. And I'd like to ask how these statistics were reached. Have they weighed every year 6? And secondly, could you tell us something about this child weight management programme? Thank you.
Thanks, Councillor White. I think in terms of the education side, that's probably one more for Heather Sandys to go into the detail. Not something that I would go into, but I agree with the basic principle. And actually, the basic principle is why the third bullet of our key priorities is to prioritise education, increasing opportunity, because that's how we'll tackle social disparity. So I don't disagree in the slightest with that. In terms of the child height and weight measurement programme, it is a statutory responsibility of the council to do it. We deliver it through our 0 to 19 service. Obviously, COVID has impacted on a whole range of services, but that's how we get those data, basically, and that's how we compare against all of the other upper-tier authority areas in the country. And as you will see, we had significant problems in terms of the levels of an unhealthy weight in Lincolnshire beforehand, and it's actually got worse since COVID. We will continue to make sure that we focus on healthy weight, and recently we've just received approval through our executive portfolio holders to enhance our One New Lincolnshire programme with a targeted programme around weight management, diet, nutrition for children and young people and their families. So we'll be investing some more money into that service through the public health grant to try to tackle that issue specifically in Lincolnshire.
Thank you.
Thank you. Just building on from Councillor White's comments, I was going to pick up later on, but on the issue of obesity. I mean, when I speak to residents, they tend to feel that one of the barriers to eating healthier is often cost-related, finding that junk-type foods are often readily available and cheap to buy. And with the county having such large pockets of deprivation, what can or is being done to address this at a local level? When we know we've got the sugar tax and so on, but really, you still see these junk foods are incredibly cheap comparably to healthier eating.
Yeah, I would agree. I think there's a couple of things. Education in what to eat and how to cook is clearly important. But whilst we do quite a lot of work in this, and there are a number of healthy food alliances across the county, most notably around Lincoln, but right the way across the county actually, working with primary schools so that children actually understand healthy diet. Of course, it's the parents, especially for younger children, who will go out and buy the food and cook it. So we do need a wider approach, and a lot of that sits within central government decisions. On that, for example, we still haven't had the public health grant allocation for 2022 yet. The council overall got its settlement before Christmas, but the public health grant has not been confirmed, so we don't know whether it's going to go up, stay where it is, which obviously would be a bit of a cut because of inflation, or go down. And so that's one of the challenges. I think in terms of things like sugar tax, again, it's a national debate. We have been promised a new obesity strategy, because certainly the Prime Minister before COVID, and actually when he personally recovered from COVID, had flagged up that he thought his weight was part of the problem in terms of how ill he was with COVID. So we are expecting a new strategy in that area, and we'll certainly be ready to go when it comes through. But we do a whole range of different work in terms of diet and nutrition, physical activity, and again, probably haven't got time to go into a huge amount of detail here. Be very happy to go back to Scrutiny and with a specific paper that goes through all of those different areas.
Thank you. I think that'd be useful. I've got Councillor Thompson next, please.
Thank you, Chairman. Good afternoon, Derek. Thank you for the report. There is a correlation with levels of dental ill health, deprivation and non-fluoridated areas. Is this a factor in the recruitment of dentists to these areas? And what is happening to extend fluoridation to these areas? Thank you.
Thank you, Councillor Thompson. In terms of there is absolutely, I would say it's not a correlation, it's a causal effect between fluoridation and decayed, missing and filled teeth. In terms of recruitment of dentists to those areas, I think just recruitment of dentists full stop into Lincolnshire and into other parts of the country, especially large rural dispersed populations like we have, is a real challenge, and is one that was the responsibility of NHS England, but is being shifted over to the ICS. So hopefully we can then have a more direct role in trying to make sure that we cover some of those gaps. In terms of how we, and if we get a broader coverage of fluoridation across Lincolnshire, the Health Act that's going through Parliament at the moment, which is being delayed somewhat, is proposing to give the responsibility for fluoridating areas back to the Secretary of State. If that happens, then we would be in a position to see whether the Secretary of State was minded to broaden out the fluoridation across Lincolnshire, and that's certainly something that Adult Care Community Wellbeing Scrutiny were interested in discussing, which is why we're going to do another paper. So happy to bring that here as well and have that debate, because clearly from a public health perspective it's almost one of those no-brainers, but clearly equally politically and from a public perception perspective, we would need to make sure that everybody felt fully informed and well, not everybody, but the majority of people in Lincolnshire were supportive of the idea to broaden out fluoridation. I would be really, really keen to do that. Obviously, as your Director of Public Health, it is probably the single best thing we can do to improve the dental health of children and people in Lincolnshire. And it's certainly something that we would want to do, but we would need to bring, obviously, our politicians with us and our population with us. So happy to come back and have that debate if that would be helpful.
Thank you again. I think that would be helpful as well. So we'll certainly bring that back. I've got Councillor Smith next.
Thank you, Chairman. It goes back to Councillor Parkin's point, and thank you, Derek, for the report. The report clearly has shown there is a systemic risk for mental health, whether that is adults' mental health or children and young people. But the pandemic has particularly exacerbated what I would call we're sitting on basically a sitting time bomb in children's mental health. As Councillor Parkin's already alluded to, I have personal and professional experience of the issues around adult mental health and the handover, which, to be blunt, in the personal experience I have had, and I know of others who have confirmed this to me, is non-existent, and you do fall through cracks. It's not entirely the fault of the situation in Lincolnshire. When the Adult Social Care Review was passed, that exacerbated an already existing problem quite substantially, actually. So I don't think it's entirely at the foot of local authorities nationally. I think there has been an issue since that legislation was passed. I would certainly welcome to be involved, should that come here at Health Scrutiny, in terms of what we can do and work, as Councillor Parkin's already alluded to, work with Derek and others, because I think we need to do some serious work in this area, because currently it's your options for mental health are exceedingly limited, especially if you don't wish to go down a medicated route. And actually speaking to someone who was a very senior qualified individual in Her Majesty's Armed Forces, you should only actually be on that medication for a period of 6 weeks. It is basically a sticking plaster. It is not meant to be used for years and years, and unfortunately there are people who are now on this medication through no fault of their own, through needing that immediate support, but who now feel unable to wean themselves off it. And that is another time when we could be essentially sitting under and not realising the problems we've got, because it's a very private matter for obvious reasons, especially if you're male. To admit you actually have a mental health, you're in a mental health crisis or you have mental health issues, it's still very difficult especially if you're male. The old adage of, stiff upper lip, men don't cry, certainly even in my generation still applies. I'm hoping it's lessening in my nieces and nephews' generation and the generations after mine, but it's still a huge systemic issue, and we need a serious conversation with it here and see what we can do. Thank you, Chairman.
Thank you. I think one of the great difficulties we have with this committee is that we have an adults committee, we have a children's committee, and so although I think there is some elements of work we can do around adults, it isn't under this remit to be going into those ins and outs.
But this is mental health, Carl, as opposed to social care.
Regardless, it is something we can look at, but it is already covered by those other two committees. And that is one of the problems we've always had going forwards. However, I have spoken to Simon and we think we can bring something forwards, but you do need to be bearing that in mind when we have these discussions. We have two committees that already do deal with those two areas. Derek, I don't know if you want to say anything further on what's been said there.
No, I think between Councillor White and Councillor Smith, we've covered that. And subject to the committee structure, I'm very, very happy to come along with, I'm sure, NHS colleagues to discuss it in whichever committee is most suitable. And certainly it is one of the priorities in the health and wellbeing strategy and for the Health and Wellbeing Board as well. So we do have structures there.
That's really useful, thank you. Got Councillor Woodliff next.
Thank you, Chairman. Hello, Derek. It's a very interesting report. I suppose from my point of view, the only thing I would say is that it's all in black and white, and it's somewhat inconvenient if the graphs are multicoloured. They are on the net, I know, but the raw reports we were supplied with, of course, were in black and white. So when it comes to black and white reporting, there needs to be some other way of defining graphs, otherwise they all look the same. You can't make a distinction between one area and another. Grey and grey and grey just looks the same. Moving on, I was amazed actually to see that the east wasn't fluoridised, the water wasn't fluoridisation protected there, given the poverty that exists in the eastern side of the country, eastern side of the county. It seems amazing that that area should be denied fluoridisation. I can't understand how that could ever have happened, but there must have been some reason for it. Maybe they were running an experiment to see whether or not teeth on the left-hand side or the eastern side of the county would be worse than those on the west. I cannot understand why fluoridisation should have been restricted just to the western side of the county. As regards the educational side of things, the question is, does the fragmentation of the education service via academies and others make it more difficult to improve the general standard of educational entertainment? We seem to be in a kind of policy whereby I mean, each school has to compete with each other school as being an entity in its own right. It makes it, I would assert, it makes it more difficult to improve the performance across the county when each school itself is an independent academy. And of course, although some academies stand on their own, many others are part of multi-academy trusts, where the academy trusts stretch right across the United Kingdom, or much across England anyway. So I wonder whether or not the philosophy behind academies makes it more difficult to improve the performance across the county. I'm also worried about further forward is I understand that Sajid Javid, as the Health Secretary, is planning to do much the same thing with the health service, to fragment it. So I don't know whether that will make it even more difficult to raise the standard of education and improve the health outcomes of the people in Lincolnshire if the NHS is further fragmented than it is. Do you have any comments on that, Derek? Or is it perhaps too political? I don't want to be too political, because that would be right. But I am concerned about how we raise the standard across the country, standards across the county for education. And I do wonder whether or not the fragmentation of the education service makes it more difficult to improve outcomes for all.
Just before Derek answers, one thing I would always say we take deep pride in with this committee is we're not a political committee, we never have been.
All right.
So I think we can avoid political, that's always useful. But
Chairman,
thank you, Derek, if you'd like to...
Chairman, have I been too political?
No, but I think it's just a point to make. We're never political in any way.
I
really.
understand,
So
but
I think it's best we all work so well together.
Yeah, I understand that. If you want me to withdraw any part of that, I'm happy to do so. So am I all right with what I've done? Thank you.
I think in terms of the detail of the education model, Heather is far better and far more educated, if you'll excuse the pun, to answer than I on that, because that's why it's a dual report, and unfortunately she couldn't make scrutiny this morning. So happy to pick that up with Heather, and maybe we could have a conversation, Councillor Woodliff, outside of the committee on that side of it. I'd read the same comments that I think you're referring to about potential Secretary of State views on almost an academisation, if there is such a word, of NHS trusts, but I haven't seen any details. So I think I'd reserve my judgment until we get the details. What I can say absolutely is there is no debate in the academic literature or in practical reality that giving a child a good education not only obviously positions them fantastically well for a good job and a good life in that sense, but has huge positive health benefits for that child as well. And the opposite is true. A poor education is one of the key drivers when you look at correlation with poor health. And that is why that third bullet point on our recommendation is so important about improving access and quality of education to our children and young people in Lincolnshire will fundamentally improve their health and well-being throughout their life course.
Thank you. Happy with that response, Councillor Woodley?
I think that's a very fair response, yes. Yeah, thank you very much, Chairman.
Thank you. I've just got one question that I don't think anyone else has expressed. So my question is that figure 13 on page 70 of our agenda pack lists 10 priorities and recommendations. How are these recommendations taken forward? For example, are they formally presented to the local NHS? Is the local NHS required to make a response? What's the answer to those, please? Thank you, Derek.
So the answer is, from an NHS side, no, they're not formally reported. There is no statutory responsibility for me to have that conversation, but suffice it to say that I will have that conversation, as I've had a conversation about the previous 2 Directors of Public Health reports with all of the chief execs of the NHS trusts, with their boards, and so we will work those through. Some of them, keeping schools and other child settings open, I can demonstrate today that we are doing that. We have I think we're probably unique in the East Midlands. We have a dedicated COVID duty desk that is staffed by public health nurses who are trained, and they provide support and advice to our head teachers, our teachers, parents who have concerns about their children, and through that we take a very proportionate approach with COVID to make sure that we're keeping our schools and our other education settings open, and we've done that right the way through the pandemic. Others around, for example, supporting children to read well and get active, we have just agreed, as I mentioned earlier in the presentation, a new service that we will commission in this space. Happy to come back and update. And then, as we were talking with Councillor White, Councillor Smith, supporting the mental health and well-being of people in Lincolnshire, children and people, but also adults, because of family impacts. And young carers looking after their parents who might have mental health problems is also an issue. Are things that we do today, we will do tomorrow, and we will need to do as we recover from COVID and actually build into the system. And I think that comes back to that conversation that we may want to have here or through other scrutinies.
Thank you, that's useful. We've had a good debate on this now, so Councillor Whittington, then briefly you'd like to come in.
I mean, one of the reasons why I've not commented is because I sit on both adults and children, so it's been there. But I think it is important that perhaps, you know, something like this, it is a question, I guess, of how those 3 committees are coordinated and how we do that. And maybe that's something that you and the other chairman of those committees can discuss. Thank you.
Thank you, Councillor Whittington. I mean, we have the upside, of course, that Simon, he's representing adults as well as this committee, so we can try and ensure that there's no crossover in that manner. I know that Hugo and I have met previously to sort of discuss similar sort of crossovers and how we take that forward, and it's certainly something I'd be willing to do, obviously, with the chairman of Children's as well. It's just making sure we're not all working, doing the same crossover there, and ensuring that that doesn't happen, and we're more NHS focused, but obviously not covering ground they are. And I think that's an important point that Simon, to be fair, and I have just been discussing sort of in the background about how we can work a little bit better towards that. So I take on board those comments and thank you for that. In which case, I would like to thank Derek for being here today. I think it's been incredibly useful. And I think some of what's come out would be good to bring back to us, because a lot of questions came out there, and I think we'd want more in-depth looks into those. And I'm sure Simon will have picked those up to make sure we bring them forwards on the work programme. So I'm going to move to the proposal, and I propose that we note the 2021 annual report from the Director of Public Health, and note the actions being taken to address the issues and recommendations presented in the previous Director of Public Health's annual report. Do I have a seconder for my proposal, please? Thank you. Thank you. All those in favour, please show. Thank you. Those are supported. And once again, thank you, Derek, for your time. It's much appreciated. We'll now move on to agenda item 9, the Humber Acute Services Programme. The committee's response to the engagement can be found on pages 79 to 82 of the report back. Simon.
Thank you, Chairman. This is the second product from the working group at the earlier this month, and a shorter product in the form of a letter, which is essentially recording the committee's interest in the Humber Acute Services Programme. The committee will be aware that that programme is at a different point to the Lincolnshire Acute Services Review, which has just completed its consultation phase. The Humber Acute Programme is looking at a consultation beginning sometime in the summer of this year, but this is just to record the committee's interest in that programme and to look forward to more detail, particularly on the patient flows from, well, in particular East Lindsey, but not exclusively the East Lindsey part of the county, into Diana, Princess of Wales and Scunthorpe General Hospital. Thank you, Chairman.
Thank you. What I'm looking for is to approve the committee's response to the engagement on the Humber Acute Services Programme. Do I have any speakers? Yeah, Councillor Harrison.
Thank you, Chairman. Just wondering, because of the number of East Lindsey patients that actually use NLAG hospitals, if they were able to or would consider including some of those residents in their consultations.
Thank you, Councillor Harrison. I think we've addressed that in the letter to ask them to consider doing so. So we'll ensure that we try and make sure that that is something that is brought forward, and we'll push certainly in our discussions with them, because I think it's incredibly important that they are picked up on. So thank you for that, Councillor Harrison. In which case, I'm going to propose that we move forward with the letter. Do I have a seconder for that, please? Thank you, Councillor Linda Wootton. All those in favour, if you could please show. Thank you. That's supported. In which case, we'll move on to agenda item 10, the work programme. Simon.
Thank you, Chairman. If the committee could refer to pages 84 and 85, which sets out the forward programme. 4 items currently listed for the 16th of February. We've got some items to add on already as a result of the item from the Director of Public Health, potentially looking at, if you like, mental health services provided by the NHS and how they link in with some of the priorities and recommendations that came out of that report. I'm also aware that that the committee requested last time that an item on cancer treatment be programmed in, and I think we still need to do that. I'm just aware of the items that are coming up, and some of the, as has already been mentioned, the update on urology services has at the request of ULHT been deferred from this agenda to next month. So it's just a question of managing the items. Thank you.
Thank you. Do I have any comments on the work programme? Councillor Harrison.
Thank you, Chairman. I'm just wondering if I could ask for any information more than there is on page 74 about the MSK conditions, because we repeatedly have the pain management service. It would be interesting to know if they've actually made any impact at all on the numbers of people with MSK problems, particularly low back pain and neck pain. Excuse me.
More than happy to add that.
Even among this committee, people have mentioned their experiences or people they're aware of.
Certainly. We'll certainly add it on. Thank you, Councillor Harrison. Any other comments, please? Yeah, Councillor Wootton.
Yeah, Chairman, I know we had this discussion before about GPs face-to-face meetings, and you tell me they are private businesses, but there's great concern that our residents can't see their GP face-to-face. And as a health scrutiny committee, could we not debate that or look into trying to either give a comment?
Yeah, I mean, we have already got it coming back in April, and if you recall, I think we did ask for a 6-month update from Dr. Kieran Sharrock, who did come and discuss this with us, I think around about October. So it wasn't that long ago we actually did have this on the item, but yeah, it's there for April anyway.
Thank you, Chair.
Any other comments, please? Yes, Councillor Woodliff.
Thank you, Chairman. What happened to the nuclear medicine side of things? What happened to the nuclear medicine side of things? Weren't they going to come back to us or something? Am I wrong on that?
It wasn't very clear at all, Councillor. Would you come forward a bit more and we might be able to hear a bit better, that's all.
Okay, what about the nuclear medicine side of things? Well, I think we were going to consider that, but what happened with that?
Yeah, thank you. I'll pass it over to Simon and he'll update.
Thank you.
Yes, thank you, Chairman. It's been put on the items to be programmed list on page 86. We've not lost sight of it. It's just that originally the presentation was made to the committee in September with a view to proposals coming forward in October. That's not happened and has been deferred on a monthly basis. So rather than keep putting it in next month's programme and then taking it off, I think we're just going to bring it forward when ULHT say that they're ready to bring it forward. Thank you, Chairman.
Thank you. It's a bit of an odd one, to be fair, Councillor Woodliff, because they came to us and asked us to put it on the agenda, and ever since we did put it on the agenda, they've asked us to take it off. So that's just where we are. Councillor Whittington.
Thanks, Mr. Chairman. Just in terms of the items to be programmed on page 86, item 3 there, the staffing challenges in hospitals. Obviously, I mean, increasingly, over many years, we've been discussing services and why services have been potentially moved, and the issue of staffing, retention of staffs, always been sort of given as a principal reason or main reason by the NHS. And obviously, I was wondering if we could give it a bit of a shove to them, a bit of a push to them to see when they're going to be able to bring that paper back, because I think that's pretty fundamental to an awful lot of the discussions we have, around that. I'm just wondering if we could sort of just try and firm up a date with them. Thanks, Mr. Chairman.
Yes, certainly there's not a problem with that. And as you'll see, the programme's starting to ease off a little bit as we've got through the acute services review and so on. So I'm sure that these items that have been put down to be programmed can come forwards now. So we'll certainly do that. Any further comments? No? In which case, are we happy with the work programme going forwards? Thank you. Okay, that's supported. Well, thank you all very much for your attendance. And I declare the meeting closed. Thank you.